Good evening to one and all. On behalf of Army Hospital RNR and Brigadier S.K. Mishra, Ati Vishesh Seva Medal, Bar to Sena Medal, Bar to Vishesh Seva Medal, I welcome you all to this All India Ophthalmological Society Scientific Committee. September 2024. We are gathered here as researchers and innovators committed to advancing knowledge and pushing the boundaries of scientific discovery. Our work in this committee is critical for shaping the future of ophthalmology. Each one of you brings unique expertise, perspectives, and insights. In today's rapidly evolving scientific landscape, our role as stewards of rigorous, ethical research has never been more crucial. We proceed today. This program will be held in 4 sessions divided into glaucoma, cataracts and IOL, retina and anti-VEGFs. Let us begin with the first session on glaucoma. I take this opportunity to invite on stage our panelists for this session. Major General Sagarika Patyal, Sena Medal, Vishesh Seva Medal, Professor Tanuj Dada, Professor Jatinder Bhalla. I request Major General J.K.S. Parihar, Sena Medal, Bar to Vishesh Seva Medal to moderate the session, please. I request all speakers to restrict their session for 10 minutes, followed by 2 minutes for discussion. With this, we start our first talk for today on how to work up a glaucoma patient by Professor Tanuj Dada, as he has to leave early.
Slides will be connected? Yes, they are. Okay. Good afternoon, everyone. Thank you so much. We call him Field Marshal Mishra ji and Dr. Namrata for this very nice collaboration between the Army and AIOSSC, and I'm delighted to be here. So today's talk is on a very basic but very important topic, and that is on how to work up a glaucoma patient. And these are the guidelines of the All India Ophthalmic Society. So they give a very comprehensive overview of a workup of glaucoma patients. So all of you should see the AIOSSC Scientific Committee website, download these guidelines, and they are very good for all the trainees on how to work up a glaucoma patient. All the investigation history is very nicely covered here. So please go through these guidelines, which are freely. So any glaucoma patient who comes, you have to answer these 3 critical questions. Does the patient have glaucoma? Is it an open angle type or angle closure type? And if he has glaucoma, is he stable or is the glaucoma progressing over the years? The basic clinical examination includes the routine ophthalmic workup. Important points to note are the relative afferent pupillary defect, the intraocular pressure, the central corneal thickness, and slit lamp signs of any inflammation, scarring in the conjunctiva. And you must do a 90-D biomicroscopy of the optic nerve head. In addition to reporting whatever the finding in the fundus, the gonioscopy is very important for any glaucoma patient. So whenever you start examining a glaucoma patient, you should first focus on the ocular surface, because that may give you telltale signs of a condition such as ocular melanosis or increased episcleral venous pressure or pigmentation, which tells you prognosis may be poor in such patients. A very simple test that you must perform any patient is to just override the lid over the conjunctiva and see the mobility. If the conjunctiva is freely mobile, this is a patient who will have a good prognosis for trabeculectomy as compared to a patient where the conjunctiva is not freely mobile. When you are examining a glaucoma patient, you must also evaluate for the meibomian gland, any meibomitis, blepharitis, and the ocular surface for dry eye, and that can be done when you are doing aplanation. You can do the fluorescent staining of the tear film, and you can pick up the tear breakup time and also do a dry eye assessment, because many of these patients do not tolerate the glaucoma medications. Slit lamp biomicroscopy is of course a routine evaluation where you can see the peripheral anterior chamber depth and just put a flashlight on the pupil to see both the RAPD as well as the depth of the anterior chamber. If the anterior chamber is shallow, you must go ahead and do a gonioscopy. The anterior chamber evaluation includes evaluation of any Krukenberg spindle on the cornea, evidence of keratic precipitates, and these peripheral anteriorly displayed Schwalbe's line that tell you that it's a case of developmental glaucoma. So on careful examination, you can rule out the pseudo-exfoliation, pupillary margin, the tears in the sphincter, traumatic glaucoma, and most important is the new vessels in the iris in cases of vascular occlusions and diabetic retinopathy. Gonioscopy has to be done, and then tonometry. So this sequence is very important. Many patients, when they are evaluated, so gonioscopy is performed and then tonometry is performed. That is an error, because gonioscopy can reduce the intraocular pressure. So always do the tonometry first, followed by gonioscopy. And when you do the intraocular pressure check, always ask the patient whether he has put the medicines. Many of them stop putting medications the day they come to the hospital. In any glaucoma patient who has a normal intraocular pressure in the office but is progressing, you have to do a diurnal variation of intraocular pressure, because many times the night time or the early morning IOP is high, which you miss in the outpatient department. And in addition, you must check the blood pressure, especially early morning or late night, because many of these patients develop nocturnal hypotension, and that is the cause for progression of glaucoma despite having a adequately controlled intraocular pressure. So how to suspect glaucoma? The intraocular pressure may be high, the optic nerve may be damaged, or the patient may have any visual field defects. So the most important evaluation is to do a stereoscopic evaluation of the optic nerve head to pick up any damage. So you have to look at the neuroretinal rim, and like in this patient, there is inferior notching of the neuroretinal rim. There is a RNFL defect picked up here, and there is a concentric enlargement of the optic cup. So these are critical signs that you need to do a stereoscopic evaluation and evaluate very carefully, spend some time on the contour of the neuroretinal rim. And if there is a deficiency, this is a typical sign of glaucoma, the notching of the inferior neuroretinal rim. So this is perhaps the earlier sign of glaucoma. And a dilated examination is very important, because you can pick up retinal nerve fiber layer defects even before there is notching of the neuroretinal rim. The gold standard investigation for a glaucoma patient is to take a color disc fundus photograph, and that is now a lot of technologies available. You can do undilated exam. So here you can see there is a very nice retinal nerve fiber layer defect with a hemorrhage visible, disc hemorrhage. So without doing any further investigation, you can straight away say this patient has a glaucomatous optic neuropathy, and then on follow-up annually you do these disc photographs and you can see whether patient is progressing or not progressing. So this is one of the most important tests for any patient of glaucoma. You have to take a disc photograph and then follow up this over time. So in the disc photograph, you have to document the neuroretinal rim and also the retinal nerve fiber layer defect, and then follow up this patient. If you don't have OCT, you can just mechanically measure these defects and see if they are progressing over time. So how you measure? You just see the distance from the blood vessels, and if this enlarges over time, that means it has progressed. So the best way to diagnose glaucoma is to corroborate the fundus photograph with this RNFL defect and notching, with the optical coherence tomography, and third is the visual field damage. So you have structural damage picked up on the disc photograph and the OCT, and that should corroborate with the functional damage on the visual field. So this patient has an inferior notching and a superior visual field defect. So this is a classical diagnosis of glaucoma when you have corroborating evidence of structural as well as functional damage. Now many patients come with where the optic disc is completely normal, and the most important thing is if they have a high IOP. So this was a recent case in the OPD, young man with IOPs 35 to 40, and the residents could not make out what is the cause. So they said maybe some trauma, and you will be very surprised, in his pocket we found this steroid cream for acne. So for pimples he was using this steroid cream. So very important to rule out any skin creams on the face, any lot of pollution. So a lot of patients are taking nasal inhalers for sinusitis, allergic rhinitis, asthma inhalers. And of course, whenever you get a sports person with high IOP, always check that they are not taking any form of androgenic steroids for building the muscles, because these can cause very severe form of glaucoma. So any patient who presents with open angles and high IOP, immediately you should start therapy if the patient's IOP is more than 30. If the IOP is more than 25, you should look for risk factors. I showed you pseudo exfoliation, pigment dispersion, a thin corneal thickness, high cup disc ratio, disc hemorrhage, family history, one-eyed patient, or any form of steroids. You have to start therapy because these patients are at risk of damage. And if a patient is very apprehensive, then it is better to counsel the patient and start therapy, because this can also lead to rise in endogenous cortisol, that is a risk factor for progression. The other important thing, which is the common error in the outpatient, is ruling out angle closure, and I'm sorry to say this is rarely done by the general ophthalmologist. So if you have a patient presenting with a shallow anterior chamber and a high intraocular pressure, you cannot let the patient go without a gonioscopy. So this is a critical test. Here you can see the trabecular meshwork is very nicely visible, followed by this white zone of the scleral spur. So if the trabecular meshwork and the scleral spur is visible, this is an open angle type of glaucoma. So that investigation must be done and reported in the outpatient card. So the critical sign you have to distinguish is in the OPD whether patient has a high IOP with an open angle or a high IOP where the iris is touching the trabecular meshwork. So you can compare these two videos. The superior video shows an open angle where trabecular meshwork is very nicely visible with this scleral spur and ciliary body band, and the video below, the iris is occluding the trabecular meshwork. So in this patient, medical therapy alone, this patient may require pilocarpine initially, and don't send him without a YAG laser iridotomy, because this is the condition which can progress to blindness. So gonioscopy you have to do in any patient presenting to you with a high intraocular pressure, especially because the angle closure carries threefold risk of blindness as compared to the open angle glaucoma. So this is very important. Although we keep on concentrating on POAG, the ratio of POAG to PACG is very high, but the blindness of PACG is 3 times. That is why gonioscopy is mandatory for any glaucoma patient. You have to rule out the iris touching the trabecular meshwork and subject these patients to YAG iridotomy. So you can see this is a patient, the angle appears closed, and then you manipulate the gonioscope and you see that the scleral spur becomes visible. So this is an angle closure where you can wait and watch. And if you see the other patient in which you have put in the gonioscopy, now the iris is attached to the trabecular meshwork. So this is a primary angle closure glaucoma. Immediately patient you have to do a YAG iridotomy, otherwise this patient is going to progress. And a very important aspect, we get a lot of elderly patients, they are taking drugs for prostate, GI problems. So many of these drugs precipitate angle closure. And especially a lot of patients don't tell you they're taking some anticholinergics and other drugs for depression, anxiety disorders. So all of them can induce angle closure. So you must remember drug issued angle closure. Unless you ask these patients specific drug history, you will miss this, and this is the cause for high IOP despite the glaucoma medications patients is carrying. The high risk category include patients who are one-eyed, patients who are on systemic medications I have already covered, diabetic patients who require repeated dilatation, And if the patient comes from far away, then it is better to do a YAG iridotomy with a narrow angle. And after you have done an iridotomy, it is very important to follow up these patients because they still may develop high IOP. So even after iridotomy, annual review is very important. So I'll just finish with one case study. So this is a typical patient who presents to you. So this patient was worked up by our residents and they said, sir, it is a physiological cupping and patient can be sent off. Now you see, when we did, this is a pseudo fundus image on the OCT. There is evidence of a retinal nerve fiber layer defect, multicolor image. So it shows a retinal nerve fiber layer defect visible, and this is confirmed on the OCT. So there is superior and inferior RNFL loss, although visual field is normal. So that is how you corroborate the disc findings with the visual field, and you are justified in starting treatment. And I'll just come to the last very important slide, that is, this is a patient presenting with normal IOP, normal pressure glaucoma diagnosed. And on disc evaluation, we found pallor of the neuroretinal rim. So if you have any patient who has pallor more than cupping, you have to order visual fields and neuroimaging, a completely open angles, and you can see in addition to the glaucoma defects, patient had a hemianopic field defect and patient had a large pituitary tumor. So this is very important. Never miss pallor more than cupping. Even if it's a glaucoma patient, patient may have developed an intracranial tumor, and you can save the life of the patient by ordering neuroimaging. So that is in summary how to work up a glaucoma patient. Please go through the AIOSSC guidelines and you will get a very detailed knowledge of what I have just presented to you. Thank you very much.
I request Major General J.K.S. Parihar to present a memento on behalf of AHRR to Professor Tanuj Dada, please. Now, I would invite Major General J.K.S. Parihar for his talk on microincision glaucoma surgery and monofocal plus lens.
Good afternoon. Good afternoon. Is it audible? Voice. Good afternoon, ladies and gentlemen. On the outset, I sincerely put my thanks and gratitude towards Professor Brigadier Sanjay Mishra and his team, AIOS office bearer, especially Professor Namrata, to give us this opportunity. I have no conflict of interest, including financial, with any product which has been described in this presentation. This is a concept of surgical management of glaucoma to achieve IOP control within acceptable limit. This acceptable limit, as the Professor Dada has already mentioned, will be varying depending upon the optic neuropathy probable changes, functional integrity, and how long these results should sustain. When we talk about the combined surgical management for coexisting cataract and glaucoma, it's not only that you have to manage glaucoma, but you have to give the best results after cataract surgery. And these results should be sustainable, and logically it should sustain for several decades. Is it possible? We have different surgical options for glaucoma surgery. It is well known to each and every one of us. I put these slides basically for the residents and younger colleagues. Now this is a nightmare for any cataract surgeon as well as glaucoma surgeon when patient is subjected to cataract surgery with glaucoma surgery or standalone. There is always a challenge to choosing the IOL, and always there the temptation to go for the multifocal IOL. But multifocal IOL patient on anti-glaucoma medicines, there is a ocular surface disorder, MGD, these are the worst cases for multifocal IOL so far the surface is concerned. When you talk about the glaucoma, what is the status of glaucoma? Is there field effect? How many medicines? If he is on more than 2 or 3 medicines, there is a probability, then these lenses are the worst choice for the for glaucoma patient. Monofocal lenses are ideal so long, but it has a limitations of the intermediate vision. And now we have the EDOF lenses with the toric platform or non-toric, which gives excellent intermediate vision in addition to a very good distance vision and compromised near vision. But the need of the near vision is now less. We need more intermediate vision for working on laptop, using software for mobiles and all those. So we all are becoming more dependent upon the intermediate vision, particularly the elderly people. So why we should go with the MIGS? What are the cases where you should go for the MIGS? The merits, yes, it has it acts on the aqueous suppression or aqueous outflow without addressing the basic pathology, which is a more issue. But main pathology is always there is a obstruction in the aqueous outflow. Medications are not taking care of this particular aspect. Hence, if you have a ab externo or ab interno surgical procedure, is logically the best choice to reach up to the almost the level of the physiological status. And it can definitely eliminate the burden of anti-glaucoma drugs by eliminating or minimizing the drug. But as usual, everybody has a limitations, whether myself or the patient or the surgical device. There is a limitations for MIGS, inflammatory, secondary glaucomas, refractory, PSCG, distorted angle, corneal pathology, severe OSD, all are, you have to put it out, not to consider. We are treating the patient for forever. We are not offering the treatment for a short term. So hence our temptation and our standard does not follow with the patient's requirement. We should not think about it. In the trabecular meshwork bypass, we have the two arms there. One is the stent placement and second is the tissue excision. In stent placement, yes, it is there. We have reached up to the eye stent inject and hydrous is about to come in our country. Tissue excisions, there is a, we have been having the trabectome GAT. Now we have got the KDB blade and ABIC again is the Professor Dada has brought it too well, and now we are waiting for excimer laser trabeculostomy to follow this trend. MIGS is not a new thing. Remember one thing, nothing is new. Whatever we are doing reinvented, whether it is a stem cell transplant. So the ileoid refining I will presume as a one of the MIGS. I had a privilege to see this procedure and equipment. Then the goniotomy, trabeculotomy, mini trap. As usual from ECC we went to the FACO with the 3-piece IOL the same way. From here to enter into the MIGS stent was the ab externo procedure. We have used it thoroughly for several years. Now it is not available in our country, but in Western world still it is there. And now it is the time for the micro stents or the KDB blade. Now the KDB blade, it has a complete removal of trabecular meshwork through a minimal invasive approach, which is contrast to the other ab interno trabeculotomy procedures, trabeculectomy like GAT and the trabectome. Now this is the case. Here you can see the IOL which is used is a 26.5 diopter. It is a high hyperopic eye, angle was moderate, and after removal of cataract we can see the angle very well with the use of the dense viscoelastic substances, and the surgery was planned for the KDB which was added, and the patient was on the one drug, and now it is quite okay. We have got the excellent visual outcome with the eye Hans lenses. The other EDOF lens is the true EDOF is a VVT lens. Now we enter into the stent business, and this is the first generation stent which has probably was the smallest when it was used 1 millimeter into 0.3 mm, 120 microns. So these are the different parameters of it. It is effective, but its longevity is not very. By and large, it goes with, audience is very less, so we can manage without it. So it is for the moderate glaucoma, those who are on 1 or 2 drugs, it can be very effective, but how long it will remain there? Probably after 3 to 5 years, the efficacy goes down up to the, say around 40%. Now we have entered into the eye stent inject. The second generation eye stent was in FDA approved in 2018, which is the smallest device, where you can see here is the 360 micron into 230 micron diameter, and now it has been, now we have eye stent W, which has a broader base of 360 microns, so it is easy to visualize when inserting and later on in the following in the post-op period to see how it goes. In fact, I confess that the most troublesome and difficult to learn is first generation inject eye stent, and this is the eye stent W is the most easy to pick up. So I would prefer and recommend that all residents, they should do regularly the gonioscopy in all their cataract cases, as the Professor Dada has mentioned, and OT as a wet lab or in the simulators, they should practice on the surgical goniotomy lenses, so that they can take up this surgery. The surgery is not a difficult, but yes, you have to orient it, and I am told the Professor Namrata has done the wonderful surgeries with the eye stent W. So the fact remains there, to advantages to get the patient off the long-term topical medications, useful in mild to moderate glaucoma. Limitation is effective for a specific time. To know its efficacy, the study should have a larger, and this is a carry-home message for all my younger colleagues, and I am sure everybody is younger than me today. ED of IOLs are the best choice today in cases of glaucoma. MIGS is relatively new category, appear unlikely to replace traditional incisional glaucoma surgery, and the trabeculectomy remains the gold standard and it will remain there. Old is gold. As MIGS horizon expands, we'll have the better stents and we'll have a more experience to go ahead with this. It is my duty to mention about the 39th National Eye Donation Fortnight, which is being observed from 25th August till tomorrow. And as a senior ophthalmologist and as president of Eye Bank Association of India, I request each and every one of you to always take up this task with a wholehearted support to the prevention of corneal blindness. And this slide I dedicate to my all students, and I feel that younger generation always does, they do better than this. Armed forces, particularly the Army Hospital, has a tradition where the Colonel Sihota, followed by Air Marshal Boperai, R.C. Sharma, they did very good job. They made their imprints, then General Vats, and after that it is a Brigadier Vats. Brigadier Mishra, who is taken over. Remaining all of us will remain like a bogies in the train. Now it is time for the younger generation, Raji and Sandeep Gupta, to take over this task, and their time is coming very soon. I am giving warning to Sanjay Mishra that they are just on the knocking, and I announce the date. They are going to take up this task on the 1st July 2034. Thank you very much. This slide has it has a scene. If you see carefully, here is the Mr. Prime Minister Narendra Modi as a younger worker with the Advani ji in the Rath Yatra. Here is the younger Sanjay Mishra is just watching surgery behind, standing me, and he's so focused. He said, when will I get a time to operate? And he did it. Wonderful.
Now I invite upon stage Director Professor Guru Nanak Eye Center, Professor Kirti Singh, to be a panelist for the session. I invite upon stage Major General Sagarika Patyal for her talk in this session on unleashing the power of comfort and efficacy in glaucoma management.
So I won't waste time and we'll go on to something. See, all of us are using ocular drugs for glaucoma. And this is something that I'm going to touch upon, although it is a sponsored talk. It would be very good if we understand why and what and why is Azarga being promoted, not by me, but perhaps by the manufacturers. And let's go on to that. My gratitude to all the Army Hospital stalwarts and AIOS members who are here. Thank you very much for this opportunity. And I'm not going, this is not working, dear. Sorry, my laptop is not working. Hi, Vikas. No. Okay, thank you very much. So we just have a look at it. I'm not going to go into details of this because Dr. Tanuj has already told us that we are dealing with a huge problem regarding glaucoma. Let us understand that the concept of glaucoma has changed. And now it is an optic neuropathy and visual field loss characterize glaucoma manifestation. Let us also understand that there are people who are going to increase, the numbers are going to increase to 1.8 million in 2040. And it's not very far away. So we all need to know about glaucoma. What we also need to understand is that there are people who are already becoming blind with glaucoma. And that is something we all need to understand. All of us are aging. It is not that that guy is going to become blind or that guy is going to suffer from glaucoma. Any one of us can suffer from glaucoma. The numbers of Indians who have been left undiagnosed is more than 90% of glaucoma remains undiagnosed in India. Why is it undiagnosed? It's $1 million question. Perhaps we are not doing our jobs very well. Let us look at the way glaucoma progresses. An asymptomatic disease. People have no idea. Kala motia, safed motia, which motia? There's no motia actually. There's no pearl sitting over there. But unfortunately, the patients gradually, when they just come to you, you come to realize that perhaps they have glaucoma. Unfortunately, you prescribe the drop. And this drop, the patient can't make out. भाई मुझे तो कोई भी problem नहीं था. मुझे तो दवाइयाँ इतनी दी गई. इसमें मेरे को इतना तकलीफ हो गया. And because he can't understand that his disease has progressed or it has improved, it doesn't improve of course, or it remains static, what does he do? Stop the medicine. Now that's the worst thing that can be done. Now what do we do therefore? We find that the person's IOP has not reduced. So what do? We put one more drop to his very big bag full of drops. And what are we doing with that? As a result of which, what we want is adherence and persistence of treatment in order to treat glaucoma. Unfortunately, we have merely added one more drop to his bag. And what will happen? His adherence and persistence to treatment will further decrease. Non-adherence with glaucoma medication is almost as high up to 60%. And people do not take their medicine. They may take the medicine as and when. They do not come for a refill. That means they will not come at the time when they require, and they'll say, "Hum yahan pe gaon mein gaye the." As a result, they couldn't get their medicines. There may be innumerable problems that the patients are really facing. So the more the number of drugs, the worse it becomes. Therefore, they don't come for appointments. They don't take their medicine. What happens? The poor glaucoma and optic disc keeps on suffering. And what do we have? Instead of looking at a beautiful disc, we have now a gradual cup. So we are going into a well of the optic nerve, and that is the deepening optic cup and resulting in glaucomatous optic neuropathy. What will happen? Obviously, our effectivity of treatment reduces, complications increase, outcomes obviously are very, very poor. So this emoji which I have shown, that if you do not adhere to glaucoma medication, then that will be a significant risk factor to your loss of vision. So what do? What are our strategies? First thing, cut off the number of medications. You try to take, instead of taking multiple. I've just spoken to Professor Tanuj Dada and asked him, what is your opinion of Trisopt? We all know, guys, what Trisopt is. 3 drugs in one. He said, fabulous. And I echo that. It's a marvelous medicine. The moment you are reducing the number of drops you are instilling in the eye, you're doing a marvelous job for the patient. Therefore, we would prefer a fixed drug rather than an unfixed combinations. Therefore, what are we doing? The amount of preservatives which are causing so many problems to the eyes, red, absolutely tomato red eyes, we are removing that. Patient is so uncomfortable. He can't blink. He has so much of watering of his eyes. So we try also, very important concept, try to select a formulation whose pH is very close to that of the eye. We know that if you give multiple medications, there are huge problems. So therefore, one thing that is a take-home message, give a fixed combination because it enables the patient to adhere to the treatment protocol much more than anything else, rather than giving him 2 bottles. Now look at this. One medication, look at the number of adherence is definitely lesser. The moment you increase, adherence is much better. The moment you increase the number of bottles, adherence goes down by 31% decrease. Therefore, what happens actually when you give those multiple bottles? Patients forget to take their medicines. Now, if you ever try to take a bottle, sometimes the bottle is very, very stiff. You can't just press it. And imagine those old arthritic hands. How are they going to press the bottles? Let's understand their problems also. And also, they're not able to come for getting their refills in time. Therefore, all of us ophthalmologists must try to simplify the patient's regimen in order to give them fewer glaucoma medications. Therefore, the approach to improve treatment outcomes in glaucoma therapy is to give fixed combinations. What happens is in fixed combinations, they improve very, very important adherence and also persistence. Now, there are various types of, as you know, fixed combinations available. Commonly, ones which are used are the PGA and the non-PGA ones. We all are using Dorzox T, brinzolamide with timolol, also using brimonidine with timolol. Now, all of you must have realized the moment you put brimonidine per se, the eye becomes red after a few months. We have to remove the patient's medicines from him. But if you give a combination, it is definitely better. Now, suppose we also have, by the way, that we can put a drug like brinzolamide and brimonidine, but these are without timolol. So there are PG analogs with timolol, and there are non-PG analogs with timolol also. So which is the correct drug that we can choose for glaucoma therapy? Check whether it is efficacious, whether it can be adhered to, and whether it is tolerable. Only one point that should be taken from this slide is that moment you reduce the pH and make it better, that means, for example, your brinzolamide timolol is only 7.2. Patient does not complain of that stink that occurs moment you put like Dorzox T. Now, on the other hand, if you take, for example, we all know what are the mechanisms of action of these drugs, so I won't go into this. But let us have a look at brinzolamide timolol versus the Dorzox timolol. Now, these are 12-month studies, and what they have found that definitely that brinzolamide and timolol combination produces a large amount of IOP reduction, and the responders, we find that the amount of patient adherence was definitely better. There was less ocular irritation with brinzolamide timolol versus the dorzolamide. This is not to say dorzolamide is bad. Please understand this is merely a study. But what comes to our notice is that when you take brinzolamide with timolol, the amount of dysgeusia, that means the amount of metallic taste in your mouth, increases with brinzolamide. Blurred vision increases because it's a suspension and not a solution. Eye irritation is also more, eye pain is also more. And most patients has been found that most patients prefer a brinzolamide timolol over dorzolamide with timolol. And patients have said that they have better comfort with brimonidine with timolol. And therefore, another observational study which was conducted in Germany, this also found that the intraocular pressure was definitely better lowered when it was shifted, when they shifted to brimonidine with timolol suspension. Patients also preferred to take this. So you have to, in real-time life, we have to check what does the patient prefer. And this is what they found, that patients preferred to take, 90% of patients preferred to take brinzolamide with timolol. And the action is definitely good. And if we look at now if we use brinzolamide timolol adjunct with PGA, then that also tells us this definitely, when we add brinzolamide timolol to a PGA, when PGA has not been able to reduce the intraocular pressure sufficiently, it is definitely better. And it reduces the intraocular pressure on a 24-hour level much better. And if you look at the, I'll just finish it. And there are many studies in this manner which have evaluated whether brinzolamide and timolol and brimonidine with timolol and whether the PG analogs, etc., how are they working. And so I end by saying that definitely if we take a fixed drug combination, it is to the benefit of our patient, not only to his eyes, to his intraocular pressure, but also to his pocket. He needs to take only those few medicines, and we'll find that the compliance is better. He will use the medicine in a much better manner, and we will get a better treatment outcome. So thank you very much for this. And I have, as I said, no financial interest or in these drugs. But yes, if you ask me, do these drugs work? Yes, they do. Thank you so much.
I would request all attendees to help themselves with running tea outside. For the next talk, I would invite Colonel Sandeep Gupta for topic monitoring glaucoma.
At the outset, I'd like to thank Team RR as well as AIOSSC for giving me this opportunity. And I'm actually humbled to be in presence of so many of my teachers here, starting with Brigadier Mishra and Brigadier Gaurav Kapoor, my immediate teachers in PG. They were our senior residents, followed by Parihar sir and Patyal ma'am and Professor Namrata during RPC days. So what I'll be covering is basically follow-up of glaucoma from a comprehensive ophthalmologist preview. And so a lot of things have already been covered by Tanuj sir, and basically it's a glaucoma is optic neuropathy, and the only and probably the most important modifiable risk factor is IOP. So what we do is we need to have follow-up these things, which include corrected IOP, gonioscopy, clinical examination, perimetry, and OCT. So primarily what we need is IOP monitoring, a structural assessment of the optic disc and RNFL, functional assessment, and interplay of these factors with each other. So what is target IOP? So target IOP is an ideal safe level of IOP, which has got multiple definitions, which primarily means that it is the mean IOP which is expected to prevent further glaucomatous damage. And the various factors are there which contribute to target IOP, including pre-treatment pressure, disease severity, and the burden of therapy, which includes the side effects of the medications and the treatments, as well as the cost of the treatment. Now, target IOP, as already explained, it depends on severity of visual field damage, rate of progression of damage, and age and life expectancy. So this is a small study which was done at RPC, which gave this small, three things: that early glaucoma, we need to have IOP somewhere in the high teens, and in severe glaucoma, somewhere in low teens, and in moderate glaucoma, somewhere in between. And the parameters were basically severity based on clinical examination as well as perimetry. So it is, multiple studies have shown that higher IOPs result in more rapid progression, while more aggressive IOP lowering delays progression. So this is how we have collected evidence from all these older studies and come to the concept of target IOP and reached the level where this concept of target IOP is there. So how do we monitor IOP in patients? So basically what we need to do is standard applanation tonometry has to be done, a corrected IOP has to be taken. Now thing to remember is we still have patients where we feel target IOP is being achieved, however the glaucoma damage is progressing. So these are the patients where we need to check pressures at different times of the day in different visits, because we might be missing IOP spikes. And again, if the patient is still progressing, you need to look at phasing or 24-hour monitoring with one of those sensor devices and contact lenses like triggerfish. And one more thing to remember is, if target IOP is still not stopping the progression of glaucoma damage, you have to look at nocturnal dip in pressure as well as the concept of ocular perfusion pressure. So in follow-up examinations, we need to do visual acuity as well as IOP, and as Tanuj sir said, a slit lamp biomicroscopy with gonioscopy is indicated when there is suspicion of development of angle closure component, or there is an unexplained change in IOP which may be because of a secondary cause of glaucoma. So what is the frequency of follow-up IOP? So if everything is well, it may be reduced to 3 monthly. However, in initial periods, it should be monthly or as soon as many times as possible. And later on, you can go up to 3 monthly to 6 monthly also, depending on whether target IOP has been achieved and progression of damage has stopped or not, and whether the control is consistent over time or not. So next we come to structural assessment, which can be done clinically and also with OCT, and the functional assessment with perimetry, and the change analysis, how they work. So as explained very well, that clinical examination is very, very important. You have to look at the size and asymmetry of the ring, the neuroretinal rim, RNFL, peripapillary atrophy, and very importantly optic disc hemorrhages, because these are very, very important signs of glaucoma progression. Then remember, more than 0.7 CD ratio is never normal, and it is always suspicious. Another red flag is asymmetry of more than 0.2 between the two cups. Then look at the ISNT rule, that if ISNT rule is maintained most of the times, it is not glaucoma. So again, if this rule is broken, then again think of something which is going wrong. Remember, glaucoma discs are not all discs are same, so there are different morphologies, so those things also have to be considered while following up patients in clinical examination. And this thing is important, a documented increase in cup size is always significant, it points towards a glaucoma only. Out of the non-specific signs, the most important is a disc hemorrhage, which has to be seen because disc hemorrhages are usually associated with progression, as I'll come to later. So usually most of the times after hemorrhages there is a subtle RNFL defect, and there are two patterns, the wedge shape or diffuse defects. So clinically also they can be picked, or they can be picked by OCTs also. And hemorrhages, as already explained, and as Tanuj sir also said, it is a risk factor for faster rate of glaucoma progression. So how do we assess the RNFL layer? So it can be done by red-free photography as well as OCT. So limitations is when you have a diffuse damage of RNFL, usually red-free photography does not pick up a RNFL defect. And the slit defects and the wedge defects are very well picked up, whereas the total atrophy, clinically you can't pick up RNFL defects. And you can see the difference, RNFL change in red-free photography is picking up the damage very well. So coming to OCTs, now we all have different machines. So you can have a Spectralis, you can have a Cirrus, you can have a RT View, but thing to remember is, once you have a patient on one machine, please follow with the same machine, because the way all machines work, they pick up RNFL thickness are different. Spectralis is the only one which directly measures RNFL thickness, whereas other two machines, they extrapolate from the volume scans. And the RNFL thickness is highest with RT View, and normative data with all the machines are different. In a busy setup, probably Cirrus is fastest, as there is no eye tracking in that. Otherwise, you should stick to one machine, and patient should be followed up on the same machine only. So what in a Cirrus, there is a parapapillary 6 millimeter cube scan which picks up the RNFL thickness, and any data which is in red is less than 99 percentile, it is a problem. So most of important in glaucoma are average RNFL thickness and RNFL thickness in the inferior quadrant. In early cases of glaucoma, there is something called a green disease. In serial scans, you may find there is thinning of the RNFL, which is significant. However, when you compare it with normative data, it is not giving you the colors of red and yellow. So this is called green disease, but a serial follow-up shows there is thinning. That is again suggestive of glaucoma progression. Another red flag is if you have a difference of more than 9 micron in average RNFL thickness between the two eyes, it is always suspicious. So one thing which I need to say, we always need to look at the disc. We should not rely on OCT data only, because there are a lot of causes of RNFL loss which are other than glaucoma. So clinical examination should complement OCT findings and vice versa. So there is something called a red disease. Here you have the data which is in red, which is showing abnormal RNFL thickness, but there is no progression. So this is very common with high myopes. So, and most of the normative data we have in OCTs, it is the specificity of OCT to detect these defects in glaucoma in myopic eyes is very, very low. So now what is happening is we are getting myopic normative database to improve specificity, and this increases specificity almost 3 times if you have these myopic data. So few more things on RNFL follow-up on OCT is, the one thing is the loss, progressive RNFL loss is faster than age-related loss. So this is one thing we should pick up. Second thing is, the RNFL thickness never reaches 0 on a average RNFL scan on OCT. It is because it becomes stable at 49 microns due to supporting tissue in the peripapillary area. So in advanced glaucoma, you don't see a lowering or further progressive RNFL loss on OCTs. Here, macular OCT is very, very effective, or clinically, HVF 10-2 is the one which is very effective in follow-up of these patients. So again, as I said, any progression should be correlated clinically as well as with fields, and you can document all these losses as event-based, where more than 5 micron one sector is suspicious, or more than 8 micron is suggestive, or trend-based, which gives us extent as well as rate of loss of RNFL on visual fields. So I'll just skip these. So this is one this thing, a follow-up where there is a progression on the RNFL and progressive chart on OCT. Then macular OCT is very effective in early glaucoma because it shows inferior macular RGC loss, which is comparable to infratemporal RNFL loss at optic nerve head. And please remember, myopic patient asymmetry between superior and inferior GC-IPL thickness gives us suspicion for glaucoma. So again, the thing to remember is the progressive macular OCT thickening is predictive of progressive RNFL thickening in the peripapillary area, and both they tell us about visual field progression. So all these things, they go together. And again, there is a guided progression analysis on OCT. Again, it tells you things in red, which when you compare with the 2 baseline scans and 2 follow-up scans. So what is happening is, it is showing us data in the summary in the end, which tells us whether the progression is there or not. So in this case, there is a progressive inferior RNFL thickness, which is given by this progression analysis. So coming to visual field analysis, we'll just go to the follow-up. Again, there are 2 things: event analysis when you compare it with a baseline, and this is again a progression analysis which is based on PD data in CTOR full threshold test, and it was part of early manifest glaucoma trial where glaucoma progression was documented, where you had 3 consistent tests showing progression 3 locations. So again, likely progression is when same or 3 or more points show deterioration are at 3 consecutive locations. So again, there is a trend analysis which basically takes into consideration your mean deviation, visual field index, as well as PSD. PSD data is very helpful in advanced glaucomas. So again, this is a progression analysis which tells us that there is a progression, and even if clinically you are not picking up, or serial scans you are not picking up, this algorithm gives us progression. So clinically it is important, again, it is important to correlate clinical findings with the RNFL findings. Here the left eye is affected. This patient, again, both eyes are affected, and clinically they are correlating with the RNFL thickness. And this is one patient where the discs were large, but other data was consistent. So basically you have to look at all these things to decide whether the patient is of glaucoma or not. So please remember, structural progression may precede functional progression and vice versa. So in early stages of pre-perimetric glaucoma, where RNFL thickness is good, mean deviation is low, VFI is high, RNFL thickness on OCT is very good to monitor glaucoma progression. In advanced glaucoma, where it is below the floor value, a 10-2 visual field and a macular OCT is very good. In moderate glaucoma, both complement each other. So in summarizing, I'll say event-based analysis on progression analysis can show if there is progression, and trend-based analysis demonstrate how fast the progression is happening. Combining structural and functional assessment modalities with trend analysis and patient-specific risk factors enables clinicians to tailor good treatment strategies individualized to the patients. And please remember, the most important thing is there is no substitute for a good clinical examination. That is mandatory in all these patients. Thank you so much.
I request Professor Kirti to present a memento to Major General JKS Parihar. I also request Colonel Sandeep Gupta to present a memento to Major General Sagarika Patyal.
With the permission of the chair and AIOS as well as Brigadier and Sanjay Mishra, I feel that a lot of things are occurring in the medical world and we cannot keep ourselves as isolated islands. We have to be part of it, right? I am a proud Bengali. I belong to Calcutta Medical College. And for that, I know that you all are with me. And so please, that slide I made specifically. If you don't mind, we'll just show it. They missed it out. S. Patyal, yes. Beta, where is it? That slide is missing. Yeah, just go next. No, it's missing. I'm sorry. Miss ho gaya hai. Koi baat nahi. Yeah, this is the one. So, just wanted to show you all this slide because I think we all are we all stand for justice, and that's what I wanted to just say. Thank you so much. Thank you, Sanjay.
I invite upon stage Major Amrita Joshi for the last talk of this session, Surgical Candidates in Glaucoma.
Good evening, everyone. Thank you for this opportunity. I'll be speaking about surgical candidates for glaucoma surgeries today. We all know that glaucoma is a group of disorders with progressive... It's a group of disorders with progressive optic neuropathy associated with visual field defects, and the most important and modifiable risk factor is intraocular pressure. The first line of treatment is usually medical management. Surgery is advised to patients who are refractory to medical management, patients who present to us with acute angle closure attacks, or patients who are non-compliant or are not tolerating the medications. There are various kinds of glaucoma surgeries like trabeculectomies, tube shunt procedures, MIGS, lasers that we have already discussed in the previous sessions. Any patient who walks into a glaucoma clinic is usually given a trial of topical medications followed by a laser procedure. We can offer laser as a primary procedure as well if we are suspecting him to be poorly compliant, followed by filtering surgeries, aqueous shunt procedures, and cyclodestructive procedures can be offered to the patient. Now, the choice of surgery would depend on the kind of glaucoma, how severe is the disease. Open angle glaucoma patients can be offered trabeculectomies, laser trabeculoplasties, and minimally invasive glaucoma surgeries. Close angle patients can be offered laser iridotomies, gonioplasties, and peripheral iridectomies and iridoplasty. Absolute eyes, neovascular glaucoma patients, congenital glaucomas can be offered a glaucoma drainage device and cyclodistractive procedures as well. Coming to a few laser procedures, laser PI is very commonly performed in most clinics. A laser is used to create a hole in the iris, allowing the aqueous humor to flow directly from the posterior chamber to the anterior chamber, thus relieving the pupillary block by photodisruption. Who would be an ideal candidate for this procedure would be anyone with an acute angle closure, phacomorphic glaucomas, iris bombays, contralateral eyes with acute angle closures, aqueous misdirection syndromes, primary angle closure suspects, primary angle closure glaucomas, chronic angle closure glaucoma patients, or mixed mechanism glaucoma patients. We had a 35-year-old lady who presented to the emergency room with ocular pain, severe blurred vision and photophobia in her left eye with visual acuity 660. Intraocular pressure was 42 millimeters of mercury. She had corneal edema with moderate conjunctival congestion, along with pigmentary deposits on the corneal endothelium. We did a gonioscopy and it revealed a convex iris approach and an intermittent peripheral anterior synechia in the left eye, thus confirming the diagnosis of an acute angle closure attack. She was managed with IV mannitol and oral carbonic anhydrase inhibitors were started for her, along with alpha-2 agonists and beta blockers. She was started on pilocarpine 2% as well. Following the intraocular pressure stabilization, she was offered a laser PI, followed by a lens extraction roughly 4 weeks from the surgery, and a contralateral PI in the other eye was done. Who would not be an ideal candidate here would be anyone with an ocular media opacity like corneal edemas, acute anterior chamber inflammations, patients with high risk eyes like very shallow flat anterior chambers, or patients who are not cooperative for a laser procedure. Coming to laser trabeculoplasties, we have argon and selective laser treatments available. They basically increase the aqueous outflow through the trabecular meshwork, thus lowering the intraocular pressure. Who would be an ideal candidate here would be people with primary open angle glaucoma, pseudo-exfoliation syndromes, pigment dispersion glaucomas, steroid-induced glaucomas, ocular hypertension patients, and narrow angle glaucoma if the iris apposition or synechia are not formed, or basically the angle is well maintained. Inflammatory glaucomas, developmental glaucoma, neovascular angle recession glaucomas, people with synechial angle closures, iridocorneal endothelial syndrome patients would not be ideal candidates here. We have a case report, 47-year-old man with the visual acuity 660 and intraocular pressure 24 millimeters of mercury, was already on maximum tolerable medications. He had white flaky material on the pupillary rim along with the anterior lens capsule. Transillumination defects were seen in mid-peripheral iris. Gonioscopy revealed sample AZ line and patchy trabecular meshwork pigmentation. The patient was advised selective laser trabeculoplasty. The IOPs were well controlled with a prostaglandin analog and an alpha-2 agonist. Coming to trabeculectomy, it's the gold standard, well-known surgery. It allows aqueous outflow from the anterior chamber to the subtenon space through a fistula and scleral flap borders, and finally collected into the episcleral and conjunctival veins. Who would be an ideal candidate for a trabeculectomy would be anyone with an uncontrolled IOP and maximum tolerable medications, documented progression of glaucoma, visual fields, progressive deterioration despite seemingly controlled IOP, poor compliance to medical treatment. It can be offered as a primary therapy in advanced disease requiring a very low target pressure, particularly in younger patients. It could be a patient preference if they want to be free of commitment of to the chronic medical treatment, as the topical medications are lifelong. Some patients are not willing for that. The relative indications would be economic considerations in country like ours. Ocular and systemic side effects of anti-glaucoma patients, medications are too much for the patient to bear. They can also be offered a trabeculectomy. Relative contraindications would be actively inflamed blind eyes with acute anterior segment neovascularization with extensive conjunctival scarring, anyone with poor ocular surface, neovascular uveitic glaucomas, traumatic glaucomas, or ocular surface disorders. We have a 24-year-old male who presented with ocular pain, blurred vision in both eyes with a visual acuity 6.9 and intraocular pressure 24 on maximum tolerable medications. His optic nerve assessment revealed a near total cupping in a laminar dot sign with visual field defects. We did a gonioscopy and it revealed a pigmented meshwork with prominent iris processes. He was started on oral carbonic anhydrase inhibitors with alpha-2 agonist and a beta blocker. We offered a augmented trap to the patient. The IOPs are well controlled post-surgery. Coming to MIGS, it's an innovative approach to treat glaucoma. It lowers the intraocular pressure by altering the aqueous humor dynamics, and it is less invasive. At our center, we are doing a trabecular bypass with iStent inject, and we are doing trabeculotomies with KDB glides. Now, who would be an ideal candidate here for MIGS would be patients who have mild to moderate glaucoma with minimal visual field defects. Patients who are primary open angle glaucomas, pigmentary glaucomas, pseudoexfoliation syndromes, patients who are non-compliant with eye drops and adverse reaction to glaucoma medications. This surgery can also be offered as a primary procedure. We do not have to wait for the glaucoma to progress. Ideal candidates would be patients with mild to moderate disease. Who would be contraindications for this surgery would be active neovascular glaucomas, angle closure glaucomas, all the patients whose angles are not angles are compromised, corneal opacities, angle dysgenesis, patients with elevated episcleral venous pressures. In our center, we have roughly done around 60 patients of the past year with phaco MIGS. The mean preoperative intraocular pressure was around 18, and after 6 months of follow-up, we have found the pressures have dropped to 13 on no medication at all. More than 60% patients are on no medication, around 30% are on one drug. Coming to cataract with glaucoma, cataract surgery alone is known to cause a reduction in IOP, roughly 15% intraocular pressure drops itself. We can combine phacoemulsification with glaucoma surgeries as well. Phaco MIGS is relatively convenient. It can be offered to the patient of cataract. It reduces the intraocular pressure by 30% as the data suggests. Coming to cyclodestructive procedures, they reduce the intraocular pressure by destroying the ciliary body. We have transpupillary thermotherapy, cyclodiode lasers, and micropulse cycloablations. They can be offered to patients with advanced glaucomas, patients with severe vision loss with no vision potential, absolute eyes, and patients with high IOP despite all conventional therapies. Coming to a gross general treatment protocol, any patient with glaucoma can be classified into open, close angles, or secondary glaucomas. If the patient is phakic, we can offer a phaco MIGS, or we can combine a cataract surgery with a trabeculectomy. If the patient is angle closure, we'll be discussing it later. And the secondary glaucomas, we can offer a drainage device to the patient. Acute angle closure in itself needs to be managed primarily by lowering the intraocular pressure, and subsequently we can do a cataract surgery if the patient is phakic in that age group, and we can offer a prophylactic PI in the other eye. So risk factor for the surgery would be patients who are older with poor health status, ocular surface disorders, certain medications. They can lead to a poor surgical outcome in these patients. We have to be very careful when we select the patient for these surgeries. Comprehensive eye exam should be done to determine the severity of glaucoma, depending on which we can offer a surgery to the patient. A detailed medical history to identify the potential risk factors along with a medical evaluation. And done in conclusion, when to offer surgery to these patients. Firstly, if they are uncontrolled with all medical treatments, the IOP is high despite everything, economic considerations. If the patient is not willing to put medications, acute angle closure patients who have to be offered laser PI or probably a cataract surgery eventually. Newer future consideration, there are studies which say that there are intracameral travoprost implants have been started in United States. We might experience, probably they might come in India, and we could have some discussion about that. Thank you so much.
I request Major General Sagarika Patel to present a memento to Colonel Sandeep Gupta and Major Amrita Joshi. I also request all the panelists and speakers for the first session of glaucoma to be on stage for a photograph, please. I again request all the attendees to help themselves with a cup of tea outside. Moving on to our second session on intraocular lenses and cataract. For this session, I request our panelists, Brigadier Vijay Mathur, Brigadier Gaurav Kapoor, Colonel Nitin Vichare, and Major Arun Baveja to be on stage, please. I request Professor Namrata Sharma to moderate the session, please. I invite Brigadier Gaurav Kapoor to deliver his talk on choosing an intraocular lens. I request all the panelists to be on stage, please.
Good afternoon, everyone. Big thank you to the faculty of RR, especially Sanjay and the IIS office bearers for getting us here for this special Armed Forces session. I've been given the topic of choosing an IOL. Now, when this topic was first given to me, it's like walking into a minefield. It's something which everybody in a private practice faces every day. You have a problem whenever a patient walks into your clinic. You have to take a decision which is going to be lifelong for the patient. For you, it is a small decision. For the patient, it is lifelong. He has to live with that IOL for the next balance years of his life. So I'll try and simplify the topic. Evolution, we all know. First implant was 1950, Dr. Ridley. This is generally the generation of IOLs that we have seen over the years. And presently we are in the generation 4 and generation 5. This is what we know as of now. And right now, the generations are basically the improved PCIOL lenses. We have various categories of PCIOLs. Now the basic problem in our practice today is a demanding patient with ever increasing expectations. The patient walks into your clinic with huge expectations. He expects to be spectacle free. He expects to have perfect distance vision, perfect intermediate vision, and perfect near vision. So how do you give him that? So as we've seen, we have progressed from spheric monofocals, which gave you a quantitative vision, aspheric monofocals, which gave you good quality vision. Then came multifocals, and now we have monofocal plus and EDOFs. So you have a wide array of lenses which are available to you in the present day. Now this is the armamentarium which is available to us today. Monofocals, multifocal, like I said, EDOF, and to add to it, toric lenses which are available in both platforms to address the astigmatism. This is the range of lenses which are available: bifocals, trifocals, EDOFs, monofocal plus, and the continuous range of vision which are available now. So there have been various meta-studies which have analyzed the studies, the comparison of the various lenses, and basically what has come out of it, if you look at this, is the pros of monofocal, and there are cons of multifocals. So both have their pros and cons, so you take the decision based on what is right for the patient, what is required. Now what are the questions that you ask when a patient walks into your OPD? These are the basic 5 questions that you need to address. In a private practice or a private patient, which IOL can you afford? That is actually a basic question which we cannot neglect. Does your lifestyle rely on near vision? Do you frequently drive at night? Do you have moderate to high astigmatism, which is where the torics come in? Or do you have any other eye conditions which need to be addressed? Now if you look at this, this basically covers 90% of the patients in your OPD, and these are the patients who will walk in and you have to address this scenario. If you take a right decision based on this, you will walk out, you will have a patient who will walk out happy of your OPD. So the patient selection is complex and objective assessment of the patient specific characteristics, the quality and quantity of astigmatism like I mentioned, the health of the ocular surface, any macular pathologies, and potential complications after surgery. So you have to assess the future also, the age of the patient, what he is likely to develop, what age he is reporting to you. So ultimately in the end your goal is a happy patient and you are a happy surgeon. So how do we go about this? There are certain things which you need to ask the patient. Initially the personality. This is an indication of how well they'll tolerate photic phenomena or be willing to sacrifice, say maybe distance vision for good near vision or vice versa. Now a basic rule of thumb is type A personalities avoid multifocals. That is the basic rule. You have a type A personality who asks you 20 questions apart from the 5 that I projected. He is going to come back to you every few days and he is going to be unhappy. So that is the basic rule that you follow. Do not identify a type A patient and please do not implant a multifocal in such patients. Easygoing patients, you have more options, they are willing to accept your advice and they'll potentially tolerate visual side effects better because they'll be open to counseling, there'll be neuroadaptation which will take place and gradually with time he'll improve. What are the visual goals? Like I said, how do they prioritize seeing at distance, intermediate or near? That depends on the patient's lifestyle. Whether he's more of a desk-bound job, he has more of an indoor job, he's a frequent, he drives frequently at night. And what does he want? Best possible distance vision, or does he want, or does he have hobbies which target the near vision? So this is what you address in your OPD. The pre-op refractive error plays a major role in such patients. Now, if you have a hyperopic patient, they generally have had poor distance vision and poor near vision. We have an unexpected visitor on stage. Hyperopic patients generally accept any type of lenses because they've been having bad vision both for distance and for near. So they're happy with any type of lenses. They'll be willing to accept whatever you offer them. This is a broad generalization. Obviously, you have various subtypes. Moderate myopes, you have to explain to them you have had near vision, good near vision your entire life. If you give you a monofocal, you're going to end up requiring near glasses, so which might not be acceptable to the patient. So there you go in for an EDOF or a multifocal. High myopes, the other advantage is that they tend to wear glasses all the time, so they are more acceptable to the fact they might end up still wearing glasses after the surgery. So this is one point which goes in your favor when you counsel such patient. So you can address them by having a monofocal set for near, an EDOF set for -1 diopter distance blur, but better range up close, or a trifocal. So you can address all these three patients, types of lenses in these patients. What do you do in young patients? Do you go for EDOFs or do you go for diffractive multifocals? There are glare and halos. They are more. They have a more active outdoor lifestyle. They are driving at night, so diffractives are generally out. And you do not know at the age of 35, 40 whether he is going to develop macular pathologies in the future, which might affect his quality of vision. Previous refractive surgery is again another complication which you need to address by topography. So this is a basic selection. It's a busy slide, but if you just go through it, this is how you decide on how to select an IOL for the right patient based on his lifestyle, based on his daily requirement, based on his whether he's been wearing glasses earlier. This will give you a breakdown of the same. So we've spoken about IOLs. I've given you a basic idea of how to select the right IOL for the patient. What are the differences between these IOLs before we go into selection? So a monofocal has a distance, single focus. A multifocal has two distinct foci, as we all know. And an EDOF breaks it down into a continuous range which changes over a distance. Now we have monofocal plus, which in addition to quality distance also gives you intermediate vision to enable the patient with daily tasks. Now, because most of the lifestyle of the patients is requiring maybe work on the mobile or work on the PC, monofocal plus is a big addition to our armamentarium, where you have a surface which is not diffractive, where you have a change in the surface, you do not have glare and halos. So you have something which you can offer a patient in place of a monofocal. So you can explain to the patient, this is your requirement, I cannot give you good near vision, but I can give you a monofocal plus, which will give you good intermediate vision, which will cover 90% of your daily tasks without giving you the complications of a full multifocal or a trifocal. So this is a big addition to our armamentarium and a big advantage. like I've explained, this is what is monofocal plus. Multifocal IOLs are generally for patients who want more spectacle independence and a greater range of vision than monofocals. And there are various lenses which are available. Trifocals are better suited, like I said, non-type A personalities, and maybe who have a more of a indoor lifestyle and less of night driving. EDOFs I have already explained. And we come to another thing which a lot of surgeons practice. There has been a lot of talk on it, mixing and matching. You can try a various mixing and matching in the same patient. Two different IOLs are often a good choice for the patient. You can mix multifocals and EDOFs. You can mix multifocals and trifocals. Depends on the requirement of the patient. I'll skip this. There are various EDOFs which are available in the market. Now, the problem is, does this end here? This is another category which has been around for a number of years. The accommodative oils, which have surprisingly not picked up because of the various factors to achieve the best accommodation possible. It is very difficult. And these are the various lenses which are available. Various technologies, but the basic problem is they do not give you better than +1 or +1.5 diopters of accommodation, which is okay in a patient who is maybe 50, 55, but beyond that, they are not very effective. Paucity of time. Now, does the story end here? There are a lot of new technologies coming up. There is something known as the IC8 Apthera, which was FDA approved in July 22, which is basically using pinhole technology to remove the aberrations and filter out peripheral defocused light. This has already been introduced, but it is suitable only for patients with only around 1.5 diopters of astigmatism. This is what the lens looks like. Also a Clearview 3, which is a segmented IOL, and also from Rayner. And there is one from BVI, the iPure, which will also be covered later in these sessions. So they have transition zones and an orientation indication, and they give you good near vision and intermediate vision. These are the various lenses. Now we have something more in the pipeline which will probably add to the confusion when a patient walks into our OPD. Rather than sorting out the confusion, you will have more options to give to the patient. There's something known as a Juvene, which is a two-part accommodating IOL that is made of two components, a base lens and a fluid lens. So this can give you accommodation of maybe +3 diopters. There's also something known as the Jelly C IOL, which is one of the newest accommodating IOLs, still in clinical trials, but likely to get approved in the next 3 to 5 years, which is set to mimic natural accommodation and relaxation. So in conclusion, the basic requirement of a patient today is more of intermediate vision. Gone are the days when you had a patient who required very good near vision. Most of our jobs, younger age group especially, anybody below the age of 55, 60, his tasks are also based on intermediate vision based on the PC or on the mobile. So a monofocal plus or an EDOF is actually the best options available to us right now. But then, like the 5 criteria I explained to you, depending on the history requirement, the daily requirements of the patient, you can do a mixing and matching or suggest the various IOLs which are available to the patient. Thank you so much.
Thank you. I just have one question. That was a very nice presentation, Dr. Gaurav. Will you mix and match one monofocal EDOF lens and a multifocal lens?
Yes, ma'am, I have tried it.
You have tried multifocal in one eye and EDOF?
I've tried multifocal with trifocal, 2 multifocals, different ads.
Okay.
I've tried an EDOF and a multifocal.
Okay. So there were no problems?
There are no problems generally. In fact, there was initially we had a problem, especially in the army setup, we had a peculiar problem. We had patients who had been implanted, say a yellow chromophore lens in one eye. And the patient came to us 3 years later where we didn't have the yellow lens in stock. So there are various studies which suggest if you mix and match a plain lens and a yellow lens, they tend to have problems with blue light. We did that also. There was an initial problem where the patient said he used to see a blue shade around some object, but with neuroadaptation over 6 to 8 weeks, the problem went away. Okay. We had this mix and match also.
Okay.
one point I would like to just highlight, you have already mentioned it, but I would highlight it further, is when selecting an IOL, the presence of dry eye and corneal surface, ocular surface. Whenever there is a defective ocular surface, multifocal should not be considered at all. EDOFs are more forgiving, but monofocal would be the lens of choice in such cases.
Thank you, sir. I would invite Colonel Bhupesh Bhatkoti for his talk on avoiding visual surprise.
At the outset, I would like to thank Brigadier Mishra sir and AIOS for giving me an opportunity. Well, after a nice talk on IOL, this is a topic which is avoiding visual surprise, which I'm sure all of us would have faced who has done cataract surgery. Now, a visual surprise is any deviation from the intended target. It is very disturbing for both patient as well as the surgeon. And if you see, the target refraction of around plus minus 0.5 can be achieved in as high as 60% of patients, and of one diopter can be achieved in as high as 95% of patients. However, still we are missing that 100%, and I think this bridge is going to be there for some time to come, though there are advances in optical biometers and the advancement in the surgical technique. So we'll be looking into the various factors, how we can go look into those, and we can avoid the visual surprise. They can be divided into pre-op, intra-op, and post-op. Now, the wrong eye, wrong patient, and the wrong IOL, these all can be decreased to an extent by maintaining a good surgical checklist. By maintaining all these transcription errors can be avoided. The major part is the biometry, and then we'll be looking into the intra-op and the post-op factors. Now, as we know, keratometry, axial length, and ACD are the three parameters. And now is the time of Swepso OCT for biometry, and the OLCR based, that is a lens star. Now, faulty keratometry is seen in these patients with dry eye, patients with corneal dystrophy, patient warp page because of corneal lens wear, a patient who has undergone a recent corneal procedure like a applanation tonometry, or a patient who has undergone a prior refractive surgery, but however the history is not forthcoming. As we know, one diopter change in corneal power will translate to one diopter change in the IOL power. Now, this is a case where one can see this is a patient of corneal epithelial dystrophy. The right eye is versi, the left eye also is affected. Now, this patient was quite asymptomatic from the cornea side, but he came for the cataract surgery. Now, he had a toric IOL. The right eye keratometry reading was not reliable. The left eye showed a toric IOL. So, however, because of the ocular surface, we decided to go ahead and treat the ocular surface first. So, he underwent PTK, and then after PTK, 4 weeks we did a repeat biometry. The toric component here, earlier it was 3.88, it increased to 4.81. So, he was implanted with this Bausch & Lomb Invista lens, which is a maximum cylinder which is available, that is 5.75, which treats 4 diopter at the corneal plane. So, the post-op, he had a refraction of around 1.5 cylinder at 5 degree and unaided visual acuity of 6.9. The patient was very happy. So, this emphasizes the role of treating the corneal pathology first and then probably going and doing a cataract surgery. Now, axial length makes a very important parameter because 1 millimeter change in axial length reading can cause up to 3 diopter change in the IOL power. So, SSOCT is very accurate, up to 0.05 mm. So, one thing is, in case now in a busy this thing we see printouts of lens star, or we see printout of the IOL Master 700. So, if you see an asterisk against the axial length, that means the axial length is being fed manually. And there we have to look for the component of corneal compression which may have happened. So, this is the causes of faulty axial length. It could be patient related, poor fixation, staphyloma, or a silicone oil filled eye. The machine limitation in patient, it is doesn't calculate well axial length in dense cataract, thick PSC, or a media opacity like vitreous hemorrhage, or it could be operator related, which is in terms of a A scan, that is corneal compression. Now, this is a IOL calculation done on a silicone oil filled eye. Here you see in the phakic eye, if I do with the phakic mode, it shows a longer eye by approximately 0.8 millimeter. So this is seen in both IOL Master as well as in LensStar. So a point to note is that they both have got this mode of silicone oil, so one has to set to that mode of silicone oil before taking the axial length. Well, this ELP is the holy grail which we all have been, cataract surgeon, been chasing, and this is the final resting place. And we see all the fourth generation newer formulas, they predict this ELP, and the fourth generation formula, they use not only keratometer, axial length, pre-op ACD, lens thickness, but also white to white and the pachymetry also. Not only the anatomy of the eye, but also the surgical technique, how the rexus is placed, what is the size, centration, capsule integrity, the post-surgical capsule contraction, as well as the IOL thickness. Some IOLs are 0.6 to 0.7 profile of the optic. Some IOLs have got a thicker profile of around 0.99. So as well as the optic haptic angulation can make a change in the effective ELP, where finally the lens will be resting in the eye. Now, A constant is normally written on the lens, and it is dependent on the type, material, on the manufacturer, but also it is dependent on the surgeon. The technique of placement of incision, what is the SIA. So ideally optimized A constant should be fixed for a surgeon, IOL and a machine. So which formula to use in a normal patient? You can go for any of the options. We normally go for a Barrett Universal or a Haigis. But in a post-refractive surgery, in an IOL Master, there are basically two formulas are there, pre-fed, that is Haigis L, and Universal Barrett True K TK. So both the methods are good for post-refractive surgery patients. In LensStar, we have Sharma's no history method and Barrett's True K in case if the previous records are not there, but in case if you know the refraction pre-op and post-op, post-LASIK, in that scenario you can use a masket and a modified masket. And then various website-based calculators are there, like ASCRS calculator and IOLcalculation.com. So normally we target for a slight myopia or a emetropia, however it should be discussed with the patient. As a general rule, for myopes, aim for a low myopia. For hyperemetropes, aim for a slight hyperopia. And these are the various intra-op factors: the surgical technique, the rexus size, whether the IOL is placed in the bag. After toric IOL, we can get a surprise. So a good visco wash after toric IOL is a must. And centration of a multifocal IOL makes a huge difference. So a good rexus and a good centered optic zone is a must. These are the post-op factors, like IOL rotation can happen, IOL tilt or decentration, capsular phimosis, CME. Now patient will come to you with typically with a history that initially when on the first day the patient was seeing very good, but on a 4-week post-op visit the patient says that the saturation is decreased. Please look for CME and you will get a slight hyperopic correction, so the myopic this thing. Similarly, CBDS can happen in an early phase because of retained visco, or it can happen in a late phase, can cause myopic shift and cause decreased vision, so which gets cleared after doing an NDAG. So now, a patient, you operated a patient and he has landed up with a refractive surprise. It is very distressing, especially if the patient is very demanding. So we do refraction at 1 month. Early in case of a toric IOL, we do a thorough ocular examination, a dilated fundal examination, recheck your records, redo the biometry, and do an OCT macula. Now, what can we offer to such a patient? This patient is going to be very unhappy, and obviously it doesn't augur well to the surgeon also, to your pride also, that you have done a surgery, a beautiful surgery, and patient has landed up. So medical management, we can offer him spectacle, contact lens, or a concept of monovision. I'll cover this. And surgically, we have laser vision, piggyback IOL, IOL reposition, or IOL exchange. Now, this is the patient. In fact, there was a couple who had come. So both of them wanted multifocal. The husband was one who actually wanted multifocal. And he had a very myotic pupil. He had only 3 millimeter myotic pupil. So I explained, I implanted a monofocal IOL in both his eyes. And for the wife, I said, I'll implant a multifocal, I'll implant a EDOF lens. So I went ahead and I did a good surgery. It was implanted a Alcon VVT, but to my surprise, she landed up with a refractive surprise of around -1.25 diopter. The patient was very unhappy. He called up he had a huge family of doctors, and more than the patient, the husband was very unhappy. So I explained to them that, gave them option of IOL exchange, but then the patient's other eye was also phakic. So I explained them the concept of monovision. I said, let me operate on the other eye. In case if you are still unhappy, I'll go ahead and I'll do the exchange of this eye. So the patient underwent cataract surgery in the left eye, and the patient was very happy with the monovision. So here again, importance of patient counseling is a very must. Now, laser vision correction can be offered in patients who have got a low refractive error, up to 2 diopter. We can offer any 3 of them. PRK, I think it would be better because it causes less dry eye, especially useful for multifocal IOLs. Piggyback IOLs when there is a hyperopic surprise and when IOL exchange is risky. So for this, we can use silicone IOLs because of the thinner profile. We have even used a 3-piece IOL, that is multi-piece, or Rayner Sulcoflex is specifically designed for this. Now, if suppose there is a IOL rotation, then definitely one has to go back and do the IOL rotation. So it is the patient's myopes and large white to white are more at risk, and it can be done with this astigmaticfix.com. This is a beautiful website. You can feed the formula here, and it tells you whether how much rotation will correct how much of the refractive error, and what will be the last final refractive error. So at times it may say that the patient vision may not be corrected and the patient may be suited for IOL exchange. At times you get, this is a case of bilateral polar cataract. The left eye was uneventful, right eye had a PCR. Left eye has been implanted with the multifocal IOL, so the surgeon implanted the multifocal IOL. One can see there's a PCR, but the rexus was very well centered and the IOL was decentered. So we did a limited anterior vitrectomy and transferrin assisted, and the same IOL was implanted in the bag with a good centered IOL. The patient had a good vision. Sometimes you have to go for IOL exchange. Like this is the patient who had, this is a lady who specifically wanted a multifocal IOL. There's a PCR, the surgeon implanted the multifocal IOL. Surprisingly, the patient was very happy. She was a wheelchair-bound patient, vision of 612, eye was quiet. But we offered her that this eye cannot be left like this. So we went ahead, did an exchange, and we did a 3-piece with a optic capture. Well, to summarize, a refractive surprise or a visual surprise after cataract surgery in the present scenario is impossible to do away with. Maybe in years to come, we may hit that near 100% happy situation. So a proper planning can lessen this, and we must identify candidates who are predisposed to refractive surgery surprises, and we must counsel them. And in spite of everything, if something wrong has happened, or if suppose the target of surprise has not been, we have got a surprise, a good patient communication and then how to manage it is the key. Thank you.
Thank you. I think this topic is very important and is open for discussion. Vivity seems to be notorious for making patients unhappy. And the second thing is, I completely agree, piggyback IOL is a very good option, especially in post-RK patients also when you are left with hyperopia. And you can always do a laser correction for residual refractive errors that are there in the form of PRK.
I would request Major Arun Baveja to join us as panelist in this session, please. I also request Professor Namrata Sharma to deliver her talk on paradigm shift in IOL delivery system.
So this is a talk which is related to specific kind of intraocular lenses. At the outset, I would really like to thank Dr. Lalit Verma sir for coming up with this idea, and Brigadier Colonel Mishra along with him, Brigadier Mishra along with him, who have crafted this program and made this happen. And this is a good idea, Armed Force special conference, and I just was suggesting and was talking to sir that we can have a session also in the forthcoming Asia Pacific Academy of Ophthalmology. Thank you so much. Everything is very well organized, and I would be talking to you. This is more of a sponsored talk, but paradigm shift in IOLs and injector systems. And this is from Hoya, the Vivinex platform. The optics are good because the spherical, for any intraocular lens, we need this good optics so that the spherical aberrations are not there. The material should be good in the form of hydrophobic acrylic material, which is glistening free and there are no calcification. The design has to be good, and this is available in this platform, which is C-loop, 13 millimeter diameter, full 6 millimeter optic. Hardly any PCO, and I think the important thing is that there are no glistenings, and also optimum rotational stability is there. The rotation that is described is only to the tune of median rotation is 1.1 degree. Otherwise, maximum that has been reported is 5 degrees. And of course, I think it has the best injector system, especially in the preloaded format. And all its injectors are really very smooth, and various options are available with them. I think this is the most important feature this lens has, and that is the glistenings are far less as compared to the glistenings which are available. And this has also been proven in studies which have been undertaken. And so that is why it is a proven material. Apart from this, the anterior and the posterior surface of the optic is quite smooth. The haptics are textured. The edges of the haptics are textured. The edges of the optic are also different, because the side edge is textured, but posterior part of it is square design, and the anterior part is quite smooth. It has a aspheric optic design which neutralizes the corneal positive abrasions, and it tolerates the anatomical misalignment, if any, and compensates for the coma abrasions. And it has two elements. The first element produces typical plus coma when off axis, and the second element is designed to produce equal and opposite coma when it is off axis. So both of them kind of neutralize each other. And so there is a 1.2 millimeter area around the central zone which induces an equal negative coma throughout a concave meniscus structure. Now the surface is ozonated, which means that the UV radiation is used so that this oxygen, it gets converted into ozone, gets stuck to the posterior part of the lens, or is present on the posterior part of the lens. And also that is why it gives a very strong adhesion between the posterior capsule and between the intraocular lens. And this is just to show the diagrammatic representation of the same, where one can see that because of the strong adhesion, there's hardly any PCO. Again, like I said, the toric platform is available, and the median rotation is only 1.1 degrees in this. Then we do have Vivinex Impress also, which is the extended enhanced monofocal intraocular lens, which is available in this platform. And again, it provides best corrected mean distance acuity as a standard monofocal IOL. In the binocular visual acuity, there is improvement by more than 1 line, and the intermediate visual acuity is also very good. Then apart from this, this also has a trifocal platform, which is a diffractive optical design, so that the intermediate at power of 1.75 diopter is there, and near at power of 3.5 diopter is there. The optical diameter remains the same, and there is a toric version also available in this. And you have a geometric option and a geometric plus option on the same platform, which is good in the sense that there are no glistenings and there is no PCO in this. So either you can use Vivinex geometric platform for both eyes, or can even use geometric for one and geometric plus for the fellow eye, so that both the intermediate and the near vision are good, as well as the distance vision is also good. So when you look at the diffractive efficiency, it is quite high, both for all the three distances, that is distance, intermediate, as well as near. And in order to, one can optimize the option of geometrics and geometrics plus depending upon the patient lifestyles. So one can give the same platform or can mix and match so that all activities are taken care of. And this is just to show the simulated optical comparisons to demonstrate the two complementary profiles of the same. Now as far as the loading is concerned, I think injectors, if you see, they are best with Hoya. We do have conventional injectors and the preloaded injectors, and it has been shown very clearly that there is less microbial contamination which is there, especially if the injectors are preloaded. With those cases where you really have to load the lenses, there is a need for intra-wound manipulation, overriding of plunger over the optic, and trauma and damage which can occur to the IOL, which does not occur with the preloaded system. And the best part is that it can go with the smallest diameter which is available, because the outer diameter of the injector tip is only 1.62 millimeter, which is the smallest nozzle for a commercially available preloaded lens. Also, one can use a one-handed push injector technique or two-handed screw injector technique. It can be delivered directly within the capsular bag or through the incision tunnel. And again, the delivery by the multi-cert system is quite easy. The steps are virtually written on the injector itself without one have to actually know the steps. On the injector itself, it is written once, so you know that in step 1 you have to put the viscoelastic into the infusion port, then it will be written 2 and 3. So one has to then release the tabs and then pull on the entire cover, and then the lens is ready for injection. So these are the various steps which I'll be showing you in the video also. Again, the characteristics of the injector are as shown here, and it, like I said, it reduces the risk of contamination and infection, and reduces the risk of the IOL damage as well. So tears, endophthalmitis, etc. are less with it. You don't have to rely too much on the skill of the person who's loading the lens, and there are no scratches because you don't touch the optics at all. It is very efficient system in the OR, and it is of course more predictable. Now, just to show the steps, all you need to do is, okay, I think I'll show you in another video because this is, so this is how we are injecting using the multi-cert system to actually inject the lens. So there is a hole which is present here, so you have to inject the viscoelastic first, and one can see as the viscoelastic moves into the injector as one instills the viscoelastic agent, and then subsequently after the viscoelastic has been injected through this hole, one has to remove the cap or the cover from it after sliding it onto one direction, and then one can do in the can use the wound to inject the lens or implant the lens, or can even do an implantation in the bag, which is done in this case. And I think the incision size does not change at all, or does not get distorted at all when you use the system, because of the size that it is, and the outer diameter is 1.62 millimeters only. This is a comparison of the various incision sizes with the various kinds of intraocular lenses when their insertions were compared, and with this kind of a platform there's hardly any distortion of the wound size itself. So almost 100% success is achieved, especially when you use these lenses, and the elimination of the manual setting variability is there. One can avoid the potential IOL loading errors and damages. I think most of the companies, they do work on the intraocular lenses, but not so much on the injectors. And I think without having any bias or any proprietary or financial interest, I can say that as far as the injector system is concerned, this is one of the best, or rather the best injector system that is available. So thank you very much for your kind attention.
Ma'am, I had a query. How would you compare this to the Clarion automated delivery system comparison?
So I think Clarion injector also works equally well, and it's automated, and this is not automated because you have to manually move it. So there are flip sides to automation also, because sometimes, you know, if it doesn't work, it kind of can get stuck. Or if you prematurely press the thing, it will just go on. You can't control it.
Retrieval is difficult if something goes.
So the reversal is difficult. I mean, there's no reversibility. But having said this, if you use it appropriately and optimally, I think the Clarion injector system is also very good. Is perhaps as good as this system, because the delivery of the intraocular lens is very smooth even in that, without having to distort the wound size. Of course, the cost also varies because of the mechanism that the automated system uses, but as far as safety is concerned, I think both of them are equally good and safe. That was a very intelligent question to ask.
Now I invite upon stage Professor Rajesh Sinha to deliver his talk on stability made simple with BVI IOLs.
Thank you very much, Brigadier Mishra, for inviting me. I mean, Army is like my second home. I always, enjoy this wonderful relationship with all the colleagues of Army. I'll be talking about advancements in IOL technology, enhanced vision lens, and also lenses with enhanced stability. Lenses have evolved quite a lot when the first time the lens was implanted. Since then, there's so much of evolution that has happened in terms of material, in terms of design, in terms of IOL delivery system. The first IOL was introduced in the year 1949 by this gentleman, Sir Harold Ridley. And since then, a lot of advancements have happened. And over the next 3 decades, the aim, the target was to get the right IOL to be implanted at the right place. And that was till almost 70s when people when they used to get the IOL implanted and retained there, they used to feel very happy about it. But then target keeps changing because the dil mange more kind of thing. It's always there. And the target now changed to having a 6x6 vision with the IOL. And that target also gradually got achieved. Then the target changed to retain that 6x6 vision by reducing PCO, so various design modification, etc., they came into practice. And that also came, that was also achieved. But then the patient again had complained that they can see good for distance, but they still require glasses for near. And that's how came the concept of multifocality and so many newer generation lenses which have evolved over time. The first concept I would say was, not the first, but yes, one of the concepts was monovision. You can implant one eye for distance and one eye for near. But then came multifocal lens, and the first multifocal lens was long back introduced. That was New View by Precision Cosme, which later on became Bausch & Lomb. And the first FDA-approved multifocal lens was Array multifocal lens. And then, of course, it evolved quite a lot with this Restore multifocal lens, which has apodized diffractive surface, and this came into practice, which is actually a bifocal lens, but of course it's called a multifocal because obviously there are 2 foci. Limitations, of course, are there because the patient do have a little bit of glare, halos, starburst, etc. And most of these lenses, they are diffractive, and they are essentially bifocal for distance and for near. But the intermediate vision, the distance from where I am seeing my laptop for my presentation, was lacking. And then came the concept of extended range of vision IOL, and the idea was to provide good intermediate vision. And the first FDA-approved extended vision lens, EDOF lens, was the Technis Symphony lens, which had a diffractive echolate design. And it increased the defocus curve and thereby enhanced the focal length. And then again, a different technology came into practice, and that was trifocal lens, wherein there were 3 foci. In some lenses, they claim for 4 foci, and that's how they could extend the depth of focus. The panoptic lens, which is very popular. No, I have no financial interest in any of these, but yes, it became very popular. But all these are diffractive lenses, and they do have limitations, wherein the patient can have glare and halos, etc. And there are some patients who are not suitable for multifocal lenses. So what to do for them? And then came the concept of enhanced monofocal, which are essentially monofocal lenses, but they do have some degree of extended depth of focus, whereby they can have some degree of intermediate vision if implanted in one eye, and a reasonably good intermediate vision if implanted in both the eyes. And for near, they can use reading glasses. So for most of the functions, they don't require glasses, but for extreme near vision, for book reading, etc., they do require glasses. And this eye-hands lens became very popular, and it came into practice. It has a technology wherein there is a continuously increasing power from periphery to the center of the lens, and that is created by higher order A sphere. Another lens which is becoming very popular these days is the IsoPure enhanced monofocal lens. It has a unique design which has it has a ring-shaped haptic, and there's a notch in the right side of the leading haptic when you're implanting. So this one has to understand. And then it uses polynomial technology, use of wavefront technology, which is used in the whole of lens. And the uniqueness of this lens is that you want asphericity differently in different power, because if you have the same asphericity in different powers, the effect will not be the same. And that is what is there in ISOPure lens, that with different dioptric power, the asphericity changes. And it has a unique material which reduces the chance of glistening in these cases, and that's how the patient can have high quality 20/20 vision without glistening. And since it is an enhanced monofocal lens, it can provide a good distance vision and a reasonable intermediate vision, and with bilateral implantation can have a good intermediate vision with no negligible photic phenomenon. This is how what I was telling, that how you should implant it. It is very easy to implant. So this is the injector. It's a partly, you can say, semi-preloaded kind of a thing. You just have to, through this groove, you have to pass the ridge of the cartridge, and then you inject fluid and then viscoelastic so that the lens moves smoothly inside the cartridge, and it can be implanted easily. This ring, as you can see here, the right side of the leading haptic has a notch, you can see here. So that is how you maintain the proper orientation of the lens, and the two leading foot plates are inside the bag, and then you push the remaining foot plates, and that is how it looks like. You can remove the viscoelastic from front, from behind, everything. It has a unique GFY material, and it has two steps which prevents PCO. One, it's a square edge design, and the second, it has a slight posterior haptic angulation, and that's why they claim that the IOL optic is in very close approximation with the posterior capsule, which is essential to prevent PCO. So we are doing some study, there's a thesis going on under me, wherein we are looking at the PC space, PC and IOL space after implantation of IOL, and we have done with some of the best IOLs available, and you can see here 172 microns. Here there is variable, it is 234 here it is very close, here it is 140. Again, here it is close to 328, so it's quite high. When we did it with the ISOPure lens, you can see here it's almost touching the posterior capsule. So square edge with almost touching. Here it is 47 microns, and with time it may touch it also. So there is enough evidence. Another eye wherein it's again 64 microns, very close to the IOL optic. And here it's almost touching. So square edge with the optic almost touching, having adhesion with the posterior capsule, prevents the chance of PCO, and that's the advantage of this lens. So this is a wonderful lens which has less chance of glistening, and as I said, the asphericity is customized for dioptric power, and that's the biggest advantage. And wavefront technology, the polynomial surface, is applied to anterior and posterior surface, and it's applied on the whole of the optic surface. That's the advantage. Just a few words about some more popular lenses, because many people, they want complete spectacle independence. They don't want even spectacle for near. So in those cases, in those eyes, we do prefer implanting a trifocal lens. So Panoptix, as you all know, is a very popular lens. Now, this fine vision trifocal lens, this was the first trifocal that was launched in the world, and that was generation 1. Now we have the generation 3 fine vision lens, and it has a unique haptic design which is double C loop with ridge technologies. You can see the ridge here. So when it folds, it doesn't get adhered to the optic, and it is quite separated, very easily to implant. And there is posterior angulated haptic, and The optic has a unique design. It is copodized. I'll just tell you what exactly is copodized. Now, some of the lenses, they have apodization. Now, when you have apodization, so you have a diffractive step like this. These are the diffractive steps, apodization. Now, when you make it a convolution of this or rounding of this step, it does not remain sharp. So this apodized step is sharp, but this copodized step is not sharp. And that is the advantage. That is why it reduces the chance of starbursts in these lenses, wherein in every trifocal you do have some risk of starburst. But because of copodization, the risk of starburst is absolutely negligible. And the contact angle, because of the double C-loop design, it is 70% greater than the single C-loop design, as we see in most of the popular designs of lenses. And it does have a combination technology. The diffractive trifocal optics is on the anterior surface of fine vision, and a toric surface is on the posterior, toricity on the posterior surface. So this is a good combination and a good combination of technologies. So in conclusion, enhanced vision lens and toric IOLs, both are very, very popular these days, and they are quite forgiving as well because they don't cause much of the photic phenomenon, and patients who are very much demanding, they are also very happy with these lenses. However, precision is the key to get optimal success, and in toric IOL, the success depends on accurate placement on the axis, and it should be retained on that axis as well, and that is better possible if you have a large contact angle of haptics and of course a good IOL PC adhesion, so that there is less chance of movement of the IOL as well as less chance of PCO. So thank you very much for your patient listening.
Dr. Dinesh, just one query I have. How does this double C loop design stand up to capsular contraction as compared to a normal C loop or a plate haptic?
Capsular?
Contraction.
Contraction. Okay. No, see, capsular contraction, first of all, there are two things. Capsular contraction mostly happens when there is some degree of fibrosis, where there is some degree of proliferation of material which these cells, and then they become fibrotic. Now, if you have a square edge design, then whatever proliferation is happening, it is happening beyond the square edge. Second, when there is an adhesion, the migration of the cells will not be there. As far as capsular contraction is concerned, if you have a greater contact angle, then it will further keep the haptic, the equator of the capsular bag stretched. So the chance of capsular contraction will further be lesser.
Thank you.
Because contact angle is 70% more than what we get in a routine single C loop.
Yeah, so in theory it should resist.
Yeah, it does.
Better than a C loop.
Yeah, yeah.
Thank you.
Yeah, Dr. Mishra has implanted many of these lenses. Mike.
So this PhysiEye lenses from BVI, we have used more than 500 in our practice, and not a single case of a capsular fibrosis, no PCO, and the design is such that the haptic and the optic, normally other lenses you can see that they are stuck and it takes a little time to unfold. Here it is such made that it doesn't stick to the optic. The optic doesn't, haptic does not stick to the optic. So it very smoothly unfurls inside the bag. But one thing one has to be very, very careful about the loading of this lens, because we have had two cases where the lens was implanted, but the trailing haptic we saw that it was broken. So one has to be very, very careful in loading these lenses, but the results are absolutely outstanding.
Yeah, it has a butterfly cartridge wherein you have to ensure that the tip of the all the four haptics, they are inside that groove. That is very essential.
Very, very important.
Yeah.
Another good practice I would suggest is capsular fibrosis. What we are talking about, what I do in all cases is do an anterior capsular polishing, especially torics, and you can, when you're operating, you actually see a rim of epithelium coming off. So it does prevent fibrosis in the long run. And it's something I do in all cases. I don't know how effective it will or required in this lens.
Earlier we used to do that, but the problem is that if you polish, the chances of dysphotopsia increases. So that's why over the last few years, people have stopped polishing the anterior capsule. And most of these lenses, they hardly have any. I mean, none of these lenses, they have any significant capsular contraction. And particularly when you have a decent capsular contact angle, nice contact angle, it keeps the capsule well stretched. So usually it doesn't happen.
Thank you, sir. I would invite Colonel Vikas Ambia to deliver his talk on prophylaxis in cataract surgery.
So good evening, everyone. First of all, I thank the organizing team for having given me the opportunity to speak in this August forum. The topic of my talk is prophylaxis in cataract surgery. So when we talk of prophylaxis in cataract surgery, the first thing that comes to our mind is endophthalmitis. So when we talk of endophthalmitis, we could divide the prophylactic measures into various stages: the pre-op stage, the operative stage, the post-operative, and the general measures that we need to take. When I talk of the pre-operative stage, it's the systemic condition of the patient that we talk of first. And in that, it's the glycemic status which is most important. So whenever a patient has a fasting blood sugar level of more than 140 or a random or postprandial blood sugar level of more than 200, it's best to postpone the case and refer the case to a physician. Then in ocular examination, it's the health of the eyelids and the eyelid margins which is most important. And never do a contact procedure on the day of surgery on a patient. Rhoplast test is a must, and always do a lacrimal surgery if the Rhoplast test comes out to be positive, or the patient has a history of lacrimal surgery in the past, or if he or she is symptomatic with epiphora or with a discharge. Now, one important question which you need to answer is, do we need preoperative topical antibiotics? Now this, we don't have any universal guidelines on this. So ultimately it's the surgeon's personal preference and practice pattern. A good guide would be the literature regarding the previous reports of microbiological profile in a local hospital or in local area. An example of this would be like, this is a large study done among two institutes, LVP and Arvind Institute, Madurai, based on which related the microbiological profile of various cases which they had over the past 1 or 2 decades. That's a good guide for a surgeon to decide what kind of regimen he wants to use or not use in his cases. So when you talk of operative measures, it's the hygiene of the patient which is very, very important. I'll not talk about this. Now the surgeons scrubbing your hands for at least a duration of 3 minutes when you're using betadine or chlorhexidine, and for 5 minutes when you're using liquid soap. There's no place for bar soaps in the operation theater. Always use potable water or purified water for washing and scrubbing hands, and always change your gloves between cases, not to mention. Again, sometimes we get casual with the kind of, with the way we wear masks. Always have your face as well as the mouth and nose covered. This is also to be observed when we give intravitreal injections. Now I come to one of the most important steps. The duration of 3 minutes of contact between betadine and the periorbital skin is very, very important. Equally important is the time of contact of 3 minutes between betadine drops and your conjunctival sac. Now, betadine has a bactericidal, virucidal, and fungicidal effect. So this is one of the most important steps. Not to mention the use of adhesive drapes, because that is how you'll be able to isolate the eyelid margins and the eyelashes. Now I come to the second most important step which is needed for prevention of endophthalmitis. It's the architecture of your wound. Now multiplanar wounds are said to be best when compared to uniplanar wounds, because these are the wounds which will have a proper sealing effect. Why you need your wound to be sealed is because if your wound is leaking, whenever there's a pressure on the globe, slightest pressure on the globe might cause your wound to gape, and that moment of hypotony which is created is going to aspirate, suck in all the flora which are on your ocular surface. So this is one of the most important steps. So always prefer a triplanar incision rather than a uniplanar incision. Equally important is the shape of your corneal wound. Try to make it squarish or near squarish. If you make it rectangular, the length of your tunnel is going to be so small that it will not have that valvular effect to bring about sealing. Another thing which I need to mention, which I have not mentioned in the slide, is always look for a fluid-tight compartment, not an airtight compartment. If you inject air into the AC and think that the wound is sealed, then we retinal surgeons use air for flattening the retina, because air has a very high surface tension. The moment that air bubble gets absorbed, the wound might leak. So always check for wound leak using fluid, not using air. You might still lead an air bubble later. Whenever your wound is, the integrity of your wound is in doubt, never hesitate to put a suture. Always put a suture whenever the wound is leaky, when you feel that the patient is not very cooperative or mentally subnormal, or if you feel that the patient has pre-existing risk factors, like if he's a diabetic, if you had a complicated cataract surgery, or if it's a resurgery. And always the suture should be buried. You don't want a nidus of infection on the corneal surface. The next question to be answered is, what is the role of intracameral antibiotics in cataract surgery? Now, this is a study on rural population of India. Use of either cefuroxime or moxifloxacin in intracamerally has been shown to reduce the incidence of endophthalmitis by 3.6-fold. Both the drugs are shown to be equally effective. So now ultimately it's a surgeon's preference. Do you want to inject or not? Any instrument which is to be used intraocularly should be changed after every single patient. The monitoring of intraocular irrigating fluids is very, very important. Firstly, they all should be in transparent pouches or bottles, which they normally are. Always check them, see them against the background of light to check for any floating opacities. Do a thumb test. You just thump that bottle on your palm and see if any sediments are rising into the fluid. All these are signs of impurities, and these batches should be discarded and reported. Not to mention, all the instruments which you use have to be autoclaved or etiosterilized. In ophthalmology, there is no place for chemical sterilization of instruments. That is one thing which should be clear about. This can work in general surgery, but not in ophthalmology. Another important question to be answered is, what is the role of post-operative topical antibiotics? What studies have shown is, if you've used intracameral antibiotics, topical post-operative antibiotics have no role in supplementing those. Okay. Ultimately, it's not mandatory. It depends again on the surgeon's preference and practice pattern. If any of the operating team has an infection, it's better to not enter the OT, and you should always limit the number of persons who are entering your operation theater. Periodic microbiological cultures, again, are very, very important. One important method is placing a 10 centimeters blood agar plate near the head end of your operating table, leaving it for half an hour. You should not be growing a gram-negative bacterium in that culture, nor a fungus. I'll skip the slide. Whenever you conduct mass surgeries, always be sure that don't perform more than 25 surgeries over a span of 4 hours. Never operate upon high-risk cases except when they are being done by experienced surgeons. Do not operate on 1-8 patients, and always perform these mass surgeries in a proper dedicated OT, not in a makeshift OT. These are my references. Now, if the second condition I would talk of when I talk of prophylaxis, it's pseudophakic CME. Now, pseudophakic CME, since I'm talking only of prophylaxis, you need to know about what are the predisposing conditions which increase the risk of CME. Among these, I would like you to remember mainly the first 3 ones: the presence of uveitis in the past or currently patient having uveitis, the presence of retinal vascular diseases, and the presence of diabetic retinopathy. Systemic conditions, again, it is diabetes, which is the foremost, the most important risk factor for developing CME. Then there are surgery-assisted risk factors. A person has already had CME in the contralateral eye, there's a very, very high chance he might develop CME in this eye too. When you've got too much of trauma during surgery, like trauma to the iris, if you've had a posterior capsular rupture, if there's been a vitreous loss, especially if there's a traction to the vitreous during surgery, if you've used a very high phaco energy, or if you've had a very, very long duration of cataract surgery, all these are risk factors for developing CME. So what do we do in these cases? So if you see this study, if you analyze the cases, so this study has compared 2 drugs, nepafenac and ketorolac, with placebo. Now, these are the cases which are not having any risk factors. So what the study says is, if the patient does not have risk factors of CME, these drugs are of no use, not significant use as prophylactic drugs for CME. However, if you see this study, which has compared patients with risk factors and patients without risk factors, The use of nepafenac does reduce the increase in macular volume which we've normally seen in patients having risk factors after cataract surgery. So what this study said was that topical nepafenac as compared to placebo is effective in reducing the incidence of CME in patients with risk factors, but is of no use in patients without risk factors. So what are the key take-home messages as far as prophylaxis of CME is concerned? You have to first look for risk factors in your cases. If they do have risk factors, then topical NSAIDs are effective. What you need to do is start them well in advance before surgery and continue for a period of approximately 3 months after surgery. I finished. Thank you.
I think, thank you. That was, I think, the most important talk today in the entire session, and that was on prophylaxis. Very well summarized. Are there any questions? Yes.
Well talk. I just wanted to ask what type of prophylactic antibiotic which you prefer is the one you try to continue the post-operatively also along with the steroid. Do you want to, let's say, start Ciplox pre-operatively, then go on to Moxiflox with prednisolone, or you say, no, it's the same medicine pre-operatively also as well as post-operatively?
Firstly, sir, as I mentioned in my slide, the choice of antibiotic would depend upon the microbiological profile of that hospital or that area. That is a good guide, but ultimately, yes, we all use fluoroquinolones. More importantly, what we need to know is we don't need to give the antibiotics post-operatively for a period of 4 weeks, just restrict it to a period of 1 week. Beyond that, it's of no use. And in that 1 week, there should be firstly the main principle to be followed is never taper off antibiotics. They should be given full dose like 4 times a day for the entire period till 1 week after the surgery. If you taper off the antibiotics, you're increasing the chance of developing resistant bacteria in the patient's ocular surface. And that is one thing which should never be done. So 1 week is good enough. Whichever antibiotic you're following pre-operatively, just continue the same post-operatively. But just for 1 week. And then you can continue with just steroids, with or without NSAIDs.
Okay, I think, thank you. With this, we come to the end of the session.
Thank you.
Thank you. Dr. Baweja, would you want to
Thank
give
you,
any
sir.
comment?
With this, we come to the end of this session. I would request Professor Lalit Verma to present memento to the speakers and panelists of this session. Professor Namrata Sharma. Brigadier Gaurav Kapoor, Brigadier Vijay Mathur, Colonel Bhupesh Bhatkoti, Professor Rajesh Sinha, Colonel Vikas Ambia, Colonel Nitin Vichare. I would also request all of you to stay on stage for the photograph, please. Major Arun Baweja. I would request for a group photograph, please. Moving on to today's third session on retina, I would request our panelists, Brigadier Paninder Kumar, Professor Rohan Chawla, Dr. Ruchir Tewari, to join on stage, please. I request Professor Lalit Verma to moderate this session, please.
Thank you so much. Without wasting time, I think we will get going. And we have, we have some very interesting talks here from the retina posterior segment. And first talk is by Brigadier Mishra about how do we approach an AMD today. You see, we have kept all practical talks so that there are some useful take-home. And Brigadier Mishra has a lot of experience in managing these patients. I'll request him to, start his talk.
Thank you, sir. At the outset, I place my heartfelt gratitude to Dr. Lalit Verma, sir, Namrata madam, for giving this opportunity. For this Armed Forces special. This is just the beginning. I wanted a slide, but I think it's not displaying here. But this is just the beginning of new forum that is Armed Forces special. And I've been very, very kind that Madam and Sir both have consented that this is going to be in all major conferences. We'll have Armed Forces special. It's an absolutely apt tribute to the Armed Forces for standing behind the nation. And also this platform will give, I'm very concerned about my junior specialists who are posted, especially in the periphery. It will give them a chance to present their experience, their teachings, and whatever they have learned in a national platform. Otherwise, they don't get a chance to present their cases. So absolutely, thank you so much, sir. We will work very hard from here onwards and make it a better and a larger platform. I will fail in my duty because I have presented this topic to all my seniors who have done this department. They have been iconic people who have been HODs earlier, right from General R.C. Sharma to Marshal Bhoparai to Kalhota, Siota, General Watts, who was the Member of Parliament from Rajya Sabha, General Pariyar sir, Madam Patyal, and Air Commodore Trihan. So it is absolutely their vision. What we are standing here is because of the vision what they thought, and we have been able to come up to their expectations. And we have now definitely a Department of Excellence. At this opportunity, I would also like to inform the platform about our vision, what our seniors had thought about, to bring up a new center now. Now the departments had moved on from being a department now to a new center. The center will start, the construction will start in December and is going to be finished by 2026. I'll fail in my duty if I don't express my gratitude for this new centers, that I was just the leader of my team. My team comprised of wonderful people like
Mishra, are you presenting or the slides are not?
Yes, sir. I want to, this is the platform I want to pay my gratitude to Pradeep and Major Sanskrita. And also the modernization has been looked after by my team like Colonel Sati, Supriya, and other students who have worked very hard to bring this.
Now I'm going to start my presentation that my experience in neovascular AMD. If you see the epidemiology, we have seen this iconic Beaver Dam study, which was conducted in '87 and showed the incidence of AMD, and which was ratified by our Indian study in Arvind Eye Hospital, where we saw that almost 0.6% of late AMD cases is prevalent in India. In 2040, we are going to lead the burden, like diabetic retinopathy, we are going to lead the burden of AMD with almost 113 million people suffering from AMD. We know AMD spectrum, it is the dry AMD which forms the bulk, that is 80% of cases, and neovascular AMD in 20% of cases. We also know that 10 to 20% of dry AMD cases progress to neovascular AMD. What I have seen the transformation of practice and diagnosis of AMD is that when we started, we have the direct ophthalmoscope, then we moved out to fundus photography, then the dilated fundus examination, to the color fundus, fundus pictures, then came the autofluorescence, which actually changed the diagnosis of AMD. Then we had different forms of OCT, and with the advent of Octa, definitely we have taken the diagnosis to a new height, and definitely we know that there's a diminishing role of FFA and ICG. Now we do only in selected cases. As far as non-vascular AMD is concerned, we know that it is just, we have to counsel the patient to avoid risk factors like smoking, exposure to sunlight, and other modification in lifestyle. In selected cases, we give antioxidant supplementations, and we educate our patient. Our patients are quite educated, so we educate our patient on for home use of AMSA grid and other, so that they can come early and report to us. And in advanced cases, we go for the low visual aids. We have seen the recommendation in ARETS 1 and ARETS 2. We also tell our patient to take a lot of green leafy vegetables and other preventive measures. Now the neovascular AMD, which is more important. The goals of AMD management has changed drastically. Now we aim, earlier we thought of halting the progression of vision loss. Now we have looking at gaining of the visual acuity with lesser side effect, and looking for a finite course of therapy with lasting and durable response, and the number of treatment should be as low as possible. Now if you see the history of AMD, what the treatment of AMD was 1981, we saw that the thermal laser was used to the latest anti-VEGF being used now. And the evolution of therapy from slowing the visual loss to gaining of the vision as seen in the Marina and Anchor study. We know that the iconic Marina and Anchor study saw the use of injection ranibizumab, and it was seen that it was the first drug to show the mean improvement of age after first year. And 95% of ranibizumab versus 64% of PDT treated eyes maintained or improved of vision at 12 months. This is the change of visual acuity when compared to vertiporfin and sham studies, that there was a gain of 10 letters. So if you see how it has progressed, the race of biologicals from efficacy when bevacizumab and ranibizumab came in, to efficacy and longevity when the aflibercept came, then durability when brolucizumab came, and with durability and safety with faricimab. Not that Pagenex or brolucizumab is safe, unsafe, but there was a lot of safety concern, which I will talk on my later slides. So we've seen the CAT trial, we've seen the original study which was done with ranibizumab and bevacizumab, and both were found to be equally effective. Again, what actually changed in a longer duration was the view 1, view 2 with the advent of VEGF trap like aflibercept, and initially it was advocated that it will be 8 to 10 weeks of inter-injection interval, but in actual life it is around 6 to 7 weeks of inter-injection interval. So this is the 7-year outcome of ranibizumab treated eyes. It's all these things, all studies have shown that all these treated eyes perform well. And they perform well when treated in treat and extend form. In all the studies, meta-analysis, but we have taken a different view on this. Normally, what is the treatment interval is that the standard is a predetermined that you keep on giving monthly injection. But the number of injections is very high, and it's not feasible in day-to-day practice. So we have evolved from that to extended and evaluation in between. So extended treatment can be the PRN. Normally, it is advocated to use a treat and extend, but we in armed forces, at least I follow the PRN therapy, because the number of injections are less, and it is possible to interrupt treatment, very important. And this is possible because we educate our patients, and our patients are not lost to follow up. As in civil population, the patients usually tend to do not follow up. But our patients, they come back diligently because we have a good network and we have good referral system. So these patients come back. And also, in armed forces, we give all this anti-VEGF free of cost. So the financial angle is also not there. So we can follow this PRN. And it's very effective in our practice. These are the meta-analyses which I told you that treat and extend is more effective than PRN. One word about brolucizumab. We know that it is a low molecular weight molecule. It's anti-VEGF, acts on the VEGF-A. Because of the low molecular weight, it delivers a greater molar dose. And what has led to this is an increased duration of action, which works both on IRF, SRF, and sub-RP fluid. We've seen the Hawk and Harrier, the iconic Hawk and Harrier trial, which was the brolucizumab was compared with the aflibercept in neovascular AMD. In Hawk, the 2 doses of brolucizumab was used, 3 and 6 milligram, compared to the aflibercept, and in Harrier, single, that is 6 milligram was used. And we have seen the study which was studied every 12 weekly doses and seen up to 48 weeks, and there was the brolucizumab was non-inferior to aflibercept at the end of 48 weeks. And this was the study, we took up this study when there was a lot of apprehension about brolucizumab. Even RP Center was not using this. We came forward, we took it as a challenge. We gave this as a thesis topic to one of the residents, and we had this international paper where we published about the efficacy and safety of brolucizumab versus aflibercept in neovascular AMD cases in Indian eyes. So here we use brolucizumab in 3 loading doses and then PRN therapy up to 48 weeks. And the patients were evaluated every 4 weeks. So and all these cases, whenever after 4 weeks, these are the cases we retreated them when the vision dropped or when the CMT OCT increased or presence of any new IRF and SRF. If we compared both the groups, they were matched well with demography, and the ocular features were also matched well. The BCVA in both the groups was similar. That means both the drug worked well. But the important part was the CMT. That means brolucizumab had a better drying effect as compared to aflibercept, and also worked well on the SRF, IRF, and the subretinal fluids. This is one senior officer who came with an PCV. We gave 1 injection of brolucizumab, and these are the serial OCT pictures of this, that he maintained even with 1 injection up to 1 year. There was no further requirement of any further injections. So what we were looking in this study was the frequency of patients achieving different injection intervals after receiving the 3rd loading dose at 8 weeks. So we have studied up to 48 weeks, and this is what I tell, that wherever the facility exists, Octa plays a very important role. This is one patient who, even though required multiple injections he required 6 brolucizumab over 1 year, but he is maintaining well now with the vision best corrected visual acuity of 6/9. So this was the final outcome, that adverse effect. If you've seen, only 1 case in our study up to 48 weeks had serious adverse effect. That means a severe vitritis. But it's important to see and tell you that with a word of caution, that it's not that if you don't have an adverse effect after the first injection, you can have adverse effect after the 3rd injection also. So keep your patients of brolucizumab under observation, call them after 1 injection and see them with the dilated fundus examination, and tell them the red flag signs, because if they go back, they should immediately report back if they have these red flag signs. So, but all these cases, we did not lose any eye. these patients were treated with oral, a milder one were treated with PST, and the major one were treated with the oral steroids along with PST, and all recovered. In fact, every patient had a better vision than the pre-injection vision level. So now that same data we have extrapolated to 104 weeks now. All these patients are now followed up. So we are also going to publish the data at 104 weeks. So what is the final result of that was intra-injection durability was of this 104 weeks is 12.6, which is slightly more what we had seen at 52 weeks. We saw 3 cases of grade 4 reactions. As far as PCV is concerned, this is a subset of a patient where we had slightly lesser response, that is 9.9 week of intra-injection durability. So our message as far as bronzimab is concerned, it works well as aflibercept, provides a longer inter-injection interval. The adverse effects are manageable, and PCV durability is slightly lesser. The safety profile of bronzimab has also been published by the VLSI, and it's seen that again whatever we have presented is almost like same thing. Then comes the faricimab. The faricimab is the latest entry. The studies in TENAI and Lucerne study which has shown the efficacy, safety and durability of faricimab versus aflibercept in neovascular AMD. It's a novel drug which acts on 2 front, angiopoietin 2 and anti-VEGF-A. So technically it can result in a higher inter-injection interval, and again it is shown a non-inferior vision gains and improved anatomical outcome versus aflibercept. These are the studies, these are the data which is published from the study. These outcomes, treat and extend arms had 12 weeks or more of inter-injection interval. The CST and vision gains were maintained during year 2. Again, we have taken up this, we have given 2 students a thesis topic of faricimab versus aflibercept in neovascular AMD, and we will again come up with the data. So our conclusion, now the diagnosis in almost everybody has shifted from being angiography, FFA and ICG to OCT and OCTA based. A non-mydriatic approach with the arrival of Optos, we are going with a non-mydriatic approach. ICG and FA is reserved only when the patient is symptomatic and the OCT does not show any obvious changes. The treatment of choice is anti-VEGF and lasers only in case of extrafoveal lesions. The choice of anti-VEGF is now we were now taking up as treatment naive cases as bronzimab versus faricimab depending upon each case. Ranibizumab we are now restricting it to pre-operative cases. Aflibercept has again come up with 8 mg dosage. We are awaiting the results of that. And in follow-up patients, as I told you, we have follow-up on PRN basis. And we tell our patients that smartphone-based Amsler grade and logMAR charts are available. So they are following up at home. And whenever they feel that there's a drop in vision or any red flag signs, they come back and immediately report to us. Thank you.
Thank you, Sanjay. Nothing better could have been possible in 10 minutes. You see, a lot of advances have occurred since Marina Anchor. And today, as I said, there are first generation anti-VEGFs and second generation anti-VEGFs. And as you rightly said, today, not only the doctor but patients are looking for efficacy, safety. That's of paramount importance. But majority of the people also want durability.
Absolutely.
And here is where the second generation anti-VEGFs, like you rightly said, the brolucimab or the Pagenex in India and faricimab comes up. I agree with you on most of the aspects, but only last slide you see where you said ranibizumab is left only in pre-op cases. It's slightly difficult because today, just because majority of the people in this country still prefer ranibizumab or eccentrics to be the first.
Absolutely, I agree with you, sir. In country where the finances, it's cost factors, ranibizumab will always be, treatment of choice for most of the people. But what I'm telling about, what I'm practicing here, because I have that
data,
and I have these injections available with me. So
luxury,
I can, you know, so
luxury. Richard is saying luxury. You have the luxury.
But yes, it's one cannot take home this message that ranibizumab is not out. It is still the wider accepted anti-VEGF, which definitely works well.
So time is not, but let me ask you one straight question. If you have an AMD patient today who requires anti-VEGF, first treatment of choice क्या है आपका? पहला drug क्या देंगे?
अब हम brolucizumab देते हैं. We give
Brolucizumab.
yes.
Why?
Again, the same thing, sir. So
because I also agree with you. I also agree. The reason I will give is because of fantastic drying effect. No molecule on the earth can.
Factor, sir. With the one injection and the patient, all the patients are educated now, sir. They will go to you. They will come to me, and when they see themselves that the drying effect, they come.
Uneducated also deserve the same benefit actually.
So the results are very good, sir, that way. And plus, inter-injection interval is, and the safety factors is now taken care of, sir.
Any comment?
Sir, since you have the luxury, you have used both brolucizumab and faricimab. Out of the two, which would be your first drug?
See, frankly telling you, faricimab, I've used now almost 50 plus injections. One thing good about faricimab is that I'm not bothered about any safety concern. So that is an added advantage of faricimab. And definitely it will give an edge when I decide.
No, what is your first molecule? You tell this only. Do not give plus minus point. You tell what is your first.
At present I'm using brolucizumab, sir, because.
Okay, okay. Message well taken. Okay, we'll move on because, you know, this would. Next speaker is none else than Pradeep Kumar. It is Dr. Pradeep's all efforts. I think we are seeing such a fantastic, you know, Armed Forces Special session being done under AIOS with due thanks to Dr. Namrata Sharma, who agreed immediately to convene this session. Pradeep will be talking about one of the rare situations where, you know, intravitreal steroids are used, I think, after diabetic patients, in a diabetic patient after vitrectomy. You see, the problem in vitrectomized eyes is the clearance of anti-VEGF agents. And we will listen from Pradeep his experience that if a patient is vitrectomized in a diabetic patient, what is your choice today?
Thank you so much, sir, for the kind introduction. And we'll like to thank AIOS from the entire Armed Forces Medical Services for giving us this opportunity. I'll start my talk. We have no financial interest. So there was a difference in vitrectomized eyes that there is a faster dissolution of hemorrhages, and the same principle applies to implants. So if you put an implant in a vitrectomized eye, it was supposed that it will dissolve faster. For solutions like anti-VEGF drugs, we knew that the half-lives were shorter. But at the same time, it has been published well that there is a lesser requirement of anti-VEGF and anti-inflammatory action in vitrectomized eyes because the vitreous, which is also a principal source of FGF, is missing. When we talk about the indications for steroids in DME surgery, it can either have a pre-operative role where you use it to reduce the inflammation till the surgery is initiated, and we have also used it as a measure to reduce vascularity, giving it about a week prior to surgery. Intraoperatively, it can be used to manage the macular edema, which you diagnose at the end of surgery, or to prevent PVR, especially in cases of combined regardies. And post-operatively, which is the most important point, that whenever we do a surgery when DME is present or anticipated, most of these patients will end up with cystic spaces post-operatively. What we already knew was that we were experimenting with leaving depot steroids at the end of VR surgery. For example, if we had done a GRT and there was a large bare choroid, we'll leave a depot of triamcinolone crystals over that plate. But whenever the steroid will dissolve, the gas will move out, the steroid will mix up into the liquid, and these patients will frequently complain of floaters. Secondly, there was no specified dose of triamcinolone in the literature. So nobody knew that how much steroid had to be left inside the eye. So we wanted to fill up this lacuna of knowledge by using Ozurdex in a standardized dose in patients of DME who had undergone vitrectomy surgery. What gave me the confidence of using this was my previous experience with using Ozurdex concurrently in cases of retinal vasculitis who were undergoing vitrectomy with us. We had used it extensively in patients of epiretinal membrane surgery, and most of VR surgeons now prefer that if the OCT is showing few cystic spaces with the ERM, they'll prefer leaving Ozurdex at the end of surgery. Also, we had used it in cases of RVOs, and post-vitrectomy, in all our experience, this was providing a longer anti-inflammatory action compared to leaving triamcinolone crystals. So in a classical case like this, where we have to manage both the PDR component as well as the PVR component because of the secondary rec component, we will like to use a longer anti-inflammatory drug. So these were our initial experiences. At this time, we used to have high gas pressure to maintain an easy insertion of the Ozurdex, and this kind of bubbling used to take place. But the correct method of placing the Ozurdex now what we follow is keep the pressure low around 20-25, gradually inject and inject inferiorly. So we designed a prospective comparative study. We took IEC clearance, 26 patients in each arm, and consecutive patients of PDR who had an indication either for TRD, an epiretinal membrane, a taut posterior hyaloid, or non-resolving vitreous hemorrhage were included. The patients underwent a detailed examination and they were observed for 24 weeks post-surgery. One question which is often asked to me is that how can you ensure that the implant doesn't move post-surgery? So this is just a simple technique where you, under visualization, put the implant inferiorly and the implant doesn't move once you come out. So we had 27 patients in the Ozurdex group and 26 in the triamcinolone group. What we realized that the best corrected visual acuity shared just a shade better with the Ozurdex implant. It was not statistically significant, so we don't say that Ozurdex works better as far as the final visual acuity is concerned. But there was a definite improvement in the central macular thickness. The center macular thickness was way lesser in Ozurdex group compared to the triamcinolone group. And why it happened probably was because there was a more requirement of re-injection in the triamcinolone group. We had kept a rescue therapy in the form of anti-VEGF injection for both the groups in case the opacity of the macula showed a recurrence of the cystic spaces. The requirement of topical steroids was also lesser in the Ozurdex implant group because the flare and cells will settle down much faster. And when it came to the reporting of the adverse effects, when we asked the patient the history of floaters, almost all the patient gave the history as yes, they were floaters. But symptomatic floaters, when we asked them to grade on a scale of 1 to 10, patients with triamcinolone in the first few weeks were extremely disturbed because of their floaters. So what we concluded was that whenever you use Ozurdex, the central macular thickness remains lesser, much more stable, and there are far lesser symptomatic adverse events. We also compared the adverse events with these. The ocular hypertension requiring topical hypotensives were about 5 cases in Ozurdex group, 9 cases in triamcinolone group, and 2 cases in the Ozurdex group on table required suturing. So it is safe to put Ozurdex at the end of pars plana vitrectomy. It gives an additional advantage in controlling long-term CME and will likely give better best corrected visual acuity in long term. The single floater is tolerated well with patients. Thank you so much.
Thank you, Pradeep. Excellent concept. The only thing is, you see, CMT going down, need for re-injection less, need for topical drops less, floaters less.
Yes, sir.
But not translating into better vision. How do you take that? Because what patient is interested in vision, not
Exactly.
in your heroic this thing, but CMT kam ho gaya, ye kam ho gaya, but vision is still the same.
So that I'll agree with you. The final visual acuity at the end of 24 weeks was almost similar between the two groups. But you realize that we had given many more anti-VEGF injections in the triamcinolone group just to control this macular edema, which was very easily controlled when we had given a single dose
No,
of...
I don't think so. We are talking of anti-VEGFs. If you anti-VEGFs, so I would not. but comparison between IV triamcinolone vis-a-vis Ozurdex. So you are saying the need for anti-VEGFs in triamcinolone group is higher?
Yes, sir, because the rescue therapy which we had kept in this trial was an anti-VEGF injection if the macular edema recurs. So whenever the macular edema will recur, we were injecting ranibizumab. So the number of injections of ranibizumab which were required over this 6-month period was much higher in the triamcinolone group rather than the Ozurdex group.
Ruchir, your take?
Sir, what would be your indication? Would you use it in all cases? I mean, of all diabetic vitrectomy or all cases with PVR? Or would you have specific indication, specific cases where you would want to use Ozurdex or say triamcinolone?
Two things. One, I have realized that if I am dealing with a combined Regardi case, I will definitely like to inject it at the end of surgery. Second is, when I have a large swollen of macula, say more than 400 microns at the beginning, or I see it intraoperatively using our IOCT, then it's a definite indication to inject.
Okay.
Thank you so much, Dr. Pradeep. So now I would like to invite Professor Lalit Verma sir for his talk on disease-related outcomes in DME.
Thank you, Rohan, and thanks to the Army Hospital as well as Dr. Namrata for arranging this symposium at a very short notice. So, after hearing Dr. Pradeep on role of steroids in vitrectomy, I will move on to another very interesting talk on disease-related outcome in DME. You see, diabetes, we all know, is increasing worldwide. Primarily, all of us eat more than required. And this is International Diabetic Federation data that every 8 seconds there are mortalities because of diabetes. 11.1% of Indian population is diabetic today. So it is nearly 101 million and not 77 million which was told a couple of years back. Today 101 million people are diabetic in this country and 136 million pre-diabetics. So everybody has to be aware of the management of diabetic retinopathy, which will increase in the coming years. And thanks to this Pizza Hut and burgers and all these things, the abdominal opacities increase and hence the diabetes. What is important is that unlike ARMD, which we heard from Sanjay Mishra, diabetic retinopathy is primarily a working aged problem. Here, you get moderate visual loss because of maculopathy in working aged adults. You see, these are 3 examples of patients who have diabetic retinopathy, ranging from non-center involving macular edema to center involving macular edema to high-risk PDR. The reason I'm showing these slides is all of them have 6/6 vision, all of them. That is the reason that all of us have to work hard to create awareness. Even ophthalmologists sometimes do not seek attention regularly in diabetic retinopathy. So blindness in diabetes is either because of maculopathy, which is moderate visual loss, or severe visual loss because of sequelae of PDR. PDR itself will not cause blindness, but it is either the maculopathy or the sequelae. Sequelae means either vitreous hemorrhage or TRDs. This is the latest classification which everybody should know. And the only thing which leads emphasis is 4-to-1 rule, which is severe retinopathy. Rest all I think are very easy to memorize. And then is this maculopathy classification, again very, very simple now. We no longer bully our residents by telling us 3 definition batao CSME and all those stuff which we have faced from our seniors. It is just no DME, center involving and non-center involving. It is all OCT based. Remember, DME is not a single entity. DME is a myriad of presentations ranging from very mild to moderate to wet-looking macula. This is a dialysis patient, to succinate rings, multiple succinate rings, and a very difficult situation of hard exudate plaque that's sitting right on the fovea. So how do we approach these patients is not a single line I can say, because everybody will have his own set of management principles. But let's summarize this by saying laser, which was the backbone treatment of DME a couple of decades back, is now a very minuscule form of treatment, except in PDR patients and high-risk PDR. So therefore, I reduced the font size here. Management of systemic factors, these 5 things we always tell. In fact, I put a stamp on my OPD card. that hemoglobin, glycemia, lipid levels, BP, kidney status, they have to be controlled. A huge chunk of DME is occupied with this pharmacotherapy, which is occupying the majority of the slide, which include VEGF inhibitors like first generation anti-VEGF, now second generation anti-VEGF, and also steroids in DME. Surgical management more relevant in tractional kind of DME. The central point to remember in DME patients is it is the chronic hyperglycemia which leads to upregulation of not only VEGF, but there are a whole lot of inflammatory mediators led by interleukins and TNF and MCPs. The effect of all these things is it leads to permeability increase and hence macular edema. And this is the various timeline, in diabetic retinopathy, although, 1856 was the first time when DR was first recognized, and it has taken so many years and years. 2010 anti-VEGFs came into vogue, and 2014 DEX implant came into the management of DR. Moving from past to present, when we were residents or even consultants at RP Center, only thing was DRS and ETDRS. And today we have multitude of management options in DME, right from anti-VEGF agents to steroids, lasers also, and surgery also. So you have to choose between these things once you are approaching a patient. All of them have limitations. There is no golden drug which is available. Anti-VEGFs have limitations of regular dosing, repeated injections, and like Pradeep was telling about vitrectomized eye, cannot use in vitrectomized eyes, and poor response in a substantial number of patients. IVTA, although not approved, is still preferred by a lot of people. Lasers have taken a backseat primarily because in DME, except for those succinate rings, in diffuse edema, it does not improve the vision. Steroids have taken a important role in the management of DME, and it is the Ozudrex as well as IVTA. Fluocinolone is not yet available, may become available next year. Anti-VEGFs, majority of the people start with anti-VEGFs, and as I said, biosimilars also have come in a reasonably big way in this country. So anti-VEGF agents in the center stage of management, and not only the innovators but biosimilars have come in a big way. Aflibercept, bevacizumab, all are used. The problem with anti-VEGFs is high treatment burden. More the number of injections, more the response. You see this graph, people who have more injections, their response is more. And this chart is very frequently brought to me by my patients. They say, Dr. Sahab, kitne injection lagate rahoge? And this, puts you down. Then you keep convincing. So it has a bearing on economics also. It is not only the physical exhaustion of patient coming again and again, but mentally also patient gets exhausted by repeated injections. And this landmark Luminous study said that in RCTs, you may have regular injections, but in real world scenario, only 50% of the patient will adhere to a regular regimen of this. So we need to optimize. We all know there will be responders and there will be non-responders in DME. And within responders, there is a high treatment burden also. And injection frequency and follow-up visits are quite a bit. You see, if you see this landmark studies, RISE and RIDE, VIVID and VISTA, 30 to 60% of patients may have suboptimal response also. You see, it's not that you give anti-VEGF, whether it is first generation, second generation, everybody will have a response. Everybody may not have a response. And this, this was a DRCT protocol eye sub-analysis, which was done by Praveen Duggal and his team. You see all these white circles, you see people are receiving injections every 4 weeks. But you see green line has improved quite a bit, improvement of 3 lines or more. But you see the red line has not improved. But still people keep persisting, giving injection. So this does not make sense. And what was concluded in this early study was that in patients, like in green line, where the response is not adequate, even after 2 interval anti-VEGF injections, you should shift. You should shift to a different injection. And then this editorial came in BJO a long time back, is diabetic retinopathy an inflammatory disease or not? And what was concluded was, you see, apart from uveitis, which has major component inflammation, and out of this vascular diseases, it is the diabetic retinopathy which has a huge chunk of inflammation also. And as I said, this is the cascade which has been described, and these are the mediators which have been studied quite well. Not only in aqueous, not only in vitreous, but people are studying these mediators in tear films also. And you see, these have been blamed for causing increased permeability and DME. And aqueous levels of anti-VEGFs also have been measured. You see all these mediators which have been listed on the left side. in the control group and in DME. And there's also a relationship which has been studied between levels as well as severity. If you see on the left side, the severity of diabetic retinopathy is increasing, and so are the levels of cytokines also increasing. And this has been studied in the vitreous also. And it has been shown that there is a association with vitreous levels as well as severity of diabetic retinopathy. More the leakage on angiography, more is the cytokine load in DME. And hence you have to pay attention to not only VEGF but also the other cytokines. And because so many inflammatory mediators are involved, hence the rationale of using anti-inflammatory drugs like steroids. Remember, all VEGFs, all anti-VEGFs are pro-inflammatory. Whatever monoclonal antibodies you inject in the vitreous cavity have a potential to increase inflammation. But steroids are anti-inflammatory. And there have been a lot of studies which you can Google on Ozudrex published. But suffice to say that dexamethasone suppresses inflammation, not only those mediators but also VEGF. And this has also been copied from Google, that if you give anti-VEGFs, typified here by bevacizumab, only thing you get is a reduction of anti-VEGF levels. But if steroids are given, here in triamcinolone, all the mediators show a downward trend. And hence the rationale of using steroids in DME. I'll just show some practical examples. This was one patient, a bank manager, who had 9 injections of an anti-VEGF given. Patient not happy because he was to deal in banks and checks. And one shot of Ozudrex brought him down. And this patient ultimately received 3 injections before he became stable. And thanks to the metabolic parameters which overtook and ultimately didn't require more injections. This is one lady which I can't forget. You see the amount of exudation which this lady has, and the OCT which is ballooned up beyond measurable limits also, more than 1400. And you see what happens after Ozudrex, and the level comes down, and another injection given, virtually normalized, although there is a component of traction here, but still remarkable response, but vision improvement was only by 1 line only. This is the summary of this patient. Even in phakic eyes, now people are using, even in phakic eyes which are recalcitrant, not responding, we today do not hesitate to give the advantage of Ozudrex. This is one example of Ozudrex from pre to post. This patient had been lasered also. You see how this patient has responded nicely. Even in patients who have operated glaucoma or well-controlled glaucoma, you see steroids have 2 issues. One is cataract, but the other is IOP. See, this patient was well controlled. This patient had issues. So we gave, even in this patient of glaucoma, responded reasonably nicely. This patient was operated glaucoma. You see this slide written here, operated glaucoma. So there's no hesitancy in my mind to give him Ozudrex. But you see the response, tremendous response in this patient. The beauty of Ozudrex is the frequency, as was being told in the previous lectures, that on average, if you see here, the interval is around more than 3-4 months, and sometimes more also. So patients tend to have less visits to hospital, less consultation, less OCT, less dependency on children to bring. So in DME, we do consider steroids, especially in people who are not responding. We do not follow that Bressler's example of keep giving anti-VEGF for 6-7 times, but even after 2-3 injections, we try to have early switch. Now we have a better anti-VEGF agents available also, you can try those also. And in patients who have recent stroke and CVA, there's no doubt. In this, I have added CKD, even kidney disease today, you see, is one of the relative concerns about usage of anti-VEGF agents. Then especially if the patient is either pseudophakic or about to become pseudophakic, and is having DME, although we try to reduce the DME by pre-operatively, but in case it is necessitated, we do not hesitate to give injection of Ozudrex right at the end of cataract surgery. Dr. Pradeep said about vitrectomized eye at the end of vitrectomy, but even at the end of cataract surgery, you should not hesitate to give this steroid. There are a lot of other indications of usage of Ozudrex, like biomarkers like drill, or a lot of hard exudates as I showed, CKD, pregnancy. In such situations, the role of steroids is of paramount importance. So in non-responders, early switch, I think, for maximizing the benefit to the patient, recent MI, CKD, and stroke, pseudophakic eyes, cataract, or to reduce monthly visits also, this drug may have a role. And this marker like drill and a lot of hard exudates, especially subfoveal hard exudates, these patients may benefit more with steroids. And CKD has recently attracted a lot of attention, kidney disease, that there may be effect on EGFR in patients who are using anti-VEGF agents. So Ozurdex can be considered as first line, especially in such situations which I just mentioned, vitrectomized eye, chronic DME, recent CVA, or biomarkers like SRF, a lot of SRF and a lot of HRF, or this drill and a lot of hypertrophic foci on OCT. In phakic also, patients who are unable to come for frequent follow-up, a lot of these dialysis patients, or cost issues, because if you calculate the cost, because if a patient has to come average of 3 to 4 months, every cost also comes down. So today, DME is not anti-VEGF only. It's not that you keep loading this patient with anti-VEGF drugs. There are a lot of other cytokines involved which we should be aware of. And the label of Ozurdex also has changed now. Previously it was, pseudophakic. Now Ozurdex label is unconditional label that you can use in DME irrespective of the lens status. And in first line, as I said, many people have adopted this. An early switch should be done. And cataract surgery and DME, I think this should be the preferred drug for usage for maximizing the visual benefit. Because once you are injecting in cataract eyes at the end of surgery, not only post-op drops go down, not only DME goes down, but Irvine gas syndrome also is taken care of. Thank you very much for your patient listening.
Thank you, sir. Thank you for a nice talk and nicely highlighting so many examples of different presentations of DME and diabetics. Such nice photographs you have shown, plus highlighting not just the role of anti-VEGF, but other inflammatory cytokines also, which is very important in DME. Any questions from the panel?
Sir, do you think that your usage of Ozurdex has changed after the introduction of the newer anti-VEGFs?
Honestly speaking, yes, it has. It has. Because nowadays, brolucimab as well as faricimab, they promise longer duration. You see, I was just same question which you are asking me. I asked a couple of people in international meetings, and they say usage of Ozurdex has gone down in favor of this longer-acting anti-VEGF agents, and they are very efficacious also because the drying effect is also very, very good.
And sir, one more question. One of the indications that we use Ozurdex right now is in uveitic cataracts, where it works really well, and we generally don't need to give oral steroids to the patient pre and post-op. So one injection of Ozurdex and then only topical medications.
In fact, today only I injected in a patient who has uveitis, plus this lady had uveitic CNVM also. So I gave a combination of anti-VEGF plus Ozurdex, just to take care of uveitic element also and CNVM also.
Right, sir.
In the same vein, probably I would also ask Dr. Mishra the same question. Like he said, in AMD now, brolucizumab has become his drug of choice. So in non-responding or patients who require multiple injections of anti-VEGF, if you want to switch, would you go for Ozurdex or would you go for the second generation anti-VEGF?
My trust or faith on brolucimab is increasing day by day. You see, the issue with brolucimab, which has been hyped more than is the fear of IOI. Fortunately, unfortunately, in Indian eyes, whatever data has been published is not very high. In my personal data of more than 255 eyes today, in our center we had four IOIs. One of them had visual loss, the rest of the 3 recovered. So the more the number of brolucimab you use, the more the confidence you gain. And believe me, brolucimab patients are such patients who ask for injections. You see, patients will ask, Dr. Sahab, wo wala injection laga do. Whereas I have not seen this line coming from any other drug, whether it is previous anti-VEGF agents, but this drug has maximal drying effect. Because of the drying effect, things improve quite a bit, and patients want this injection now. Only thing is the fear has to go away because there's no definitive this thing. But we had a lot of discussion. How will this fear go away? Fear will go away if you use more. And the other caveat here is that this patient needs slightly more closer follow-up. You see, if anti-VEGF I gave, I will call him after say 3-4 weeks. But brolucimab patient, I will call him after 5 days to 7 days just to see that I am not missing IOI. And I will photograph all these patients also. And at the slightest incidence of IOI, whether it is vitreous or aqueous, you should load this patient with steroids, and mind you, these reactions will go away. If you ignore this and if you follow this patient late, and by chance if patient has an IOI, then things are not very rosy.
Thank you. Sir, your experience, sir?
So what sir has said rightly, that if I have to switch, I'll switch to the second generation of anti-VEGFs. But as I keep telling that, as far as brolucizumab is concerned, you have to be very cautious. In the sense, still, I mean, we have given almost more than 2,000 injections in our center, and none of the eyes was lost. But we're still very cautious. So it is, even after the second or third injection, you can get an eye. So be careful. Keep these patients on a closer follow-up. Very important. You can't, like other anti-VEGFs, you give injection and say that come back after 4 weeks. No.
The other thing, Mishra, is that in your study which you mentioned, we know, I normally don't load these patients. I do not give every 4 weeks brolucizumab.
No, we have stopped that.
Of the
We have
study
one
said,
injection in PRN.
Yeah.
We are not giving it.
Because this can be safely given PRN. This can be safely given PRN.
So we have taken him in DME cases. We have taken as a straight away as PRN. No loading dose of brolucizumab.
So I think the message is that all these newer agents are also quite effective, but the patients have to be followed up closely. Look out for these IOIs, adverse events, if any, and no loading dose required in such patients.
Absolutely.
You can go ahead with PRN.
And frequency should be slightly not less than 6 to 8 weeks. You see, don't call them after every 4 weeks for another dosage of. The difference between brolucizumab and other is the wow effect. The wow effect occurs with this agent. The drying, if you see, occurs maximally. Even more than 1400, 1500, they'll come down very fast.
Thank you, sir. So now I invite the last speaker. Dr. Brigadier Poninder Kumar sir, for a talk on cataract and DME.
Foremost, I would like to thank Brigadier Sanjay Mishra and the entire faculty of Army Hospital for giving us this opportunity. So my topic is cataract surgery in diabetes in general and diabetic macular edema in specific, and partly has been covered by my previous speakers, so I'll highlight the ones which have not been covered. So about 1/3 of the diabetic population has diabetic retinopathy, and the main cause of vision loss, diabetic macular edema, is there in 5 to 6% patients, and we know cataract is more common and at a younger age group. So we will limit ourselves to the pathophysiology of DME, its incidence, the surgery and management strategies. No. I hope you can hear me now. So pathophysiology and incidence, I am not very good in biochemistry, and my previous speaker, Dr. Lalit Verma, has explained in detail, so we will skip this, except that blood-retinal barrier we are much more familiar with. So these figures also have been given. An aging population with longer life expectancy also means that not only prevalence of diabetes, but diabetic retinopathy will also increase. So this is how you do a detailed examination, and as the previous speakers have brought out, now OCT has taken over entirely. Fluorescent angiography, ICG, as Brigadier Mishra brought out, has become very limited, because diagnosis, monitoring and therapeutic selection and even gauging the response of the treatment is all done through OCT or OCTA. So these are the various ways we are monitoring the DME through OCT. So now we are going to the specific cataract surgery, and we must know that there may be transient refractive changes related to the lens. If you have unstable blood sugar, hyperglycemia may induce myopia, and if you give intensive therapy, then the patient may become hyperopic. So these changes in corneal topographic parameters can be a potential error not only in keratorefractive but also in our biometric calculation. Then you may like to do full scatter PRP laser pre-operatively, then post-operatively if the cataract is progressing. These are the various factors which we should control: the glycemic control, including lipid profile, blood pressure. Now, timing of the surgery. There is general consensus that we should go in for early cataract surgery. Why? Because improved visual outcomes are there with early cataract surgery. If the cataract becomes more opaque, then you are unable to diagnose the macular edema or the neovascularization and treat with laser. This has also been brought out very well, use of steroids as well as anti-VEGFs. So most of the studies have seen that there is no significant difference in the BCVA whether you give steroids or anti-VEGFs before cataract or with cataract surgery, but the drying effect of steroids is better and for a longer time obviously. So there may be some more potential benefits of CMT being reduced with steroids. Of course, IOP and related complications are more common with steroids. So this is in a nutshell that visual acuity is similar, retinal thickness is less with steroids, and marginally IOP related adverse events may be more, especially in steroid responders. This has been discussed in detail, and I will just come to the methodology that, like in vitrectomy, we like to give anti-VEGFs a few days or a week earlier, but in most cases of cataract surgery with DME, we like to give on the same day or the same sitting the cataract surgery and the anti-VEGF, more so for practical purposes. As brought out earlier, macular photocoagulation is out. If patient has any signs of neovascularization, PRP should be done. Now the choice of intraocular lens. Most feel that a hydrophobic, acrylic, single piece with a large optic, probably monofocal is the IOL of choice in diabetic macular edema, though some people have tried multifocal also. Small incision phacoemulsification, 2 mm, 2.2 mm would be preferred with a large capsular access, avoid complications, intensive post-op inflammation control. A surgeon should be prepared for poor pupil dilatation and potential complications related to corneal epithelial defects, endothelial cell loss, and maybe bleeding if he has NVI. Multifocal lens should be avoided, and there are some studies which say that blue light filtering IOLs may offer some advantages. So surgical technique, small incision, potential complications we have explained. Post-operative outcome and prognosis are good with mild, moderate NPDR with minimal DME, but once you have severe DME and PDR, the results become rather less. So what are the major complications? PCO, macular edema may progress. There have been some studies which say that use of topical NSAIDs and steroids help in patients of DME, but some studies have negated that this doesn't actually occur. Use of anti-VEGF agents, I leave it to the choice of the surgeon. And despite all these measures, many studies have indicated that there may be a progress in diabetic retinopathy. So if any vitrectomy also is indicated, then obviously a combined vitrectomy with cataract should be done. So these are the future directions and ongoing research targeted to OCT, angio, new drug delivery systems, and going in for personalized treatment. So these are the two OCTs I picked up yesterday. Now this is a OCT of a patient who was given, who underwent cataract surgery in the left eye. Now since there was hardly any, I have not got the pre-op slide, but the other slide is there. And he has developed, he underwent about a month back, and he has developed macular edema in the left eye, for which anti-VEGF has been given now. So that has been a slip up from our side. Now this is another patient which I picked up yesterday. Again, diabetic macular edema, both eyes, and we have given anti-VEGFs. And this we have not given him steroid, but we have been giving him anti-VEGFs for the last 6 months, and we have reached up to Vabysmo, and the response still is suboptimal. In the other eye also, we have gone with the similar regime, and the response is slightly better. So, as far as to conclude, I would like to make a point that as far as AMD is concerned, and BRVO or even CRVO, I don't know whether the panelists will agree with me or not, but I find that the treatment regime for AMD, that is neovascular AMD, and BRVO and even CRVO, whether ischemic or non-ischemic, is rather simpler. But DME and PDR with so many variables, the choices are tremendous, and at times the chance of going in for errors, I feel, are more in diabetics rather than as compared to people having neovascular AMD or RVOs. That is my personal opinion, and I rest my case. Thank you.
Thank you, Puninder. Before we call Colonel Raji for ROP talk, you see, cataract surgery and DME, the reason for this talk primarily is because, in contrast to routine DME, which we manage and where we have an option of anti-VEGFs and steroids or newer anti-VEGFs, remember that cataract surgery and DME both are pro-inflammatory. Cataract surgery also causes inflammation, and DME also has a component of inflammation. And that is the reason I think here the role of steroids is much, much higher compared to anti-VEGF agents. Because what Dr. Rohan asked me this question today, in this era of newer anti-VEGF agents, in a patient who is undergoing cataract surgery, I would still not use anti-VEGF agents in patients who are undergoing cataract surgery. You see, we had been in the previous, after cataract surgery, we were giving, eccentrics or other anti-VEGF agents. But today, if the cataract surgery is being done and patient has DME, I think we should prefer Ozurdex rather than preferring anti-VEGF agents. The reason being, as I said, both are inflammatory. Cataract surgery is inflammatory, DME has inflammatory component, and if you inject another pro-inflammatory, that is MABs in monoclonal antibodies, so further possibility is there. There are instances where patient preoperatively is dry and he has undergone cataract surgery. Even in those patients, instead of giving anti-VEGF agent, we should prefer a steroid. The reason being, the possibility of worsening is much higher. Apart from other advantages which Colonel Pradeep had said about no usage of drops and longevity, Irvine gas syndrome, everything else. So once there is a cataract surgery being done and DME concurrent is there, which is stable or which is unstable, but cataract should be significant enough. Cataract should be significant then only. Otherwise, we all try to dry the macula beforehand, before surgery. And if not, if cataract is significant, DME is also significant, then you should combine cataract surgery with Ozurdex given at the end of cataract surgery. There are a lot of people like PGI group in Chandigarh, they want to give it before. Some people give 2 weeks before. But by and large, just for the benefit of patient's convenience, it is at the end of cataract surgery which is the best time. Rohan, any comment on this?
I would agree, sir, that as the previous dictum is, like sir also said, if you can manage DME prior to cataract surgery, manage it first as best as you can and then go ahead with cataract surgery. And if you cannot, then at the same time you can inject an steroid implant along with it.
Okay, Ruchir, any comment? Let's now call the last speaker of this session. Another very important talk on ROP. ROP previously was laser, and laser, but now a lot of these babies have benefited because so many studies, be it ROP, rainbow trial, so many studies have come which have told about the efficacy or sometimes preference for anti-VEGFs. Yes, Colonel Raji.
Brigadier Mishra and this team and the AIOSSC for giving me this opportunity to speak in this forum. From the adult retina, we are now shifting into the pediatric retina. I'll be talking about the role of anti-VEGF therapy in ROP. As we all know, it is a vasoproliferative disorder of the retina which commonly affect the preterm babies. And in India, we are constituting almost 23.7% of preterm babies because of increase in the IVF and other facilities. And it is around 10% of the world's ROP blindness or related blindness are seen in India. And 16 to 17% of all premature babies, they land up with some stage of ROP. And it is more when they are of lower birth weight or with a lower gestational age group. A brief talk about the pathogenesis. Basically, it happens in two phases. The initial phase is a hypoxia-induced phase, where there is reduction in the VEGF, and there will be cessation of the progression of the vessels. And the phase 2, where there is, because of the hypoxia, there is less vascularization leading to hypoxia, which causes increase in the VEGF level and proliferation. This is the time where the anti-VEGF play a role in controlling the progression of the disease. And as we all know, there are different zones and stages of ROP, and in the latest ROP revised classification, they have removed the AP ROP terminology and introduced aggressive ROP. And for the zone 2, there is another classification. The zone has come as zone 2 posterior, and they have introduced notch. And the stage 5 has been again divided into 3 different types. When should we screen these babies? As per the guidelines in India, we should follow that 30-day strategy that is teased in after the birth of the baby. We should actually plan 4 weeks after the birth, and if the babies are of very low birth weight, that is less than 28 weeks of birth, then gestation we should plan earlier, that is by 2 to 3 weeks of time. How do we manage the ROP? Depending upon the severity, it is being classified into 2 types, type 1 and type 2, and it is type 1 which needs better kind of management, and especially the one which is in the zone 1 area. So initially it was the cryotherapy, followed by laser photocoagulation, as sir already said, and that is still remains a standard of care in management of ROP. But with laser, it has its own disadvantages. First is, we have seen various studies have shown that the chances of myopia, the babies developing high myopia, is more with patients who are treated with laser. And during the procedure, they can develop apnea, bradycardia. Then some patients, when we go in single setting, they can develop anterior segment ischemia also. And loss of visual field, that is a very when you compare with the anti-VEGFs, when you're treating a disease in the zone 1, almost the entire field of the baby is knocked out because of the laser. And obviously the time taken, it is more. That is how the anti-VEGF came into play. And the role of anti-VEGF, it plays a very major role in the ischemic phase, and they inhibit the abnormal blood vessel growth. At the same time, it is shown that it does not inhibit the progression of the normal vessels. These are the various indications in which we should use anti-VEGF. As I said, posterior zone 1 disease, cases of aggressive ROP, and in patients with poor visibility due to media opacities or vitreous hemorrhage, or even when we are planning for a surgery, we want to reduce the vascularity. In that condition, situation also, we can give anti-VEGF before the surgery. And in cases where there is recurrent of disease after laser or persistence of the disease is there. It can be used as monotherapy only anti-VEGF, or a combination of anti-VEGF plus laser or rescue therapy. These are the various anti-VEGF which has been tried in treatment of ROP. Bevacizumab was the first one which was tried, followed by ranibizumab, and then now aflibercept also. I would like to talk about 2-3 terminologies. What is reactivation and regression and a persistent avascular retina? Reactivation is there is a growth of new tufts of vessels. After the ridge has, after you giving the treatment, the disease has regressed, and then again it has reactivated with the new tufts of vessels which are seen at the ridge. And regression is the disease is going away, either a response to the treatment or sometime spontaneously. And it is seen more fast when we use anti-VEGFs. Another terminology is persistent anti-avascular retina. This is more we are seeing when we are using only anti-VEGF. The vessels, they don't progress beyond a certain level. So these kind of patients, they require a longer follow-up. A few words about various anti-VEGF. The first one was, which was tried was bevacizumab, and it was used for type 1 ROP involving the zone 1, and the most common, the dose which was used was half of adult dose, because we all think that babies have half size of the adults. So 0.625 milligram was used, and there are other dosages were varying from 0.03 milligram to 1.2 milligram. And what was the advantage of bevacizumab was, though it was an off-label use, it was inexpensive, and usually these babies we could maintain on a single injection, and because the drug used to take time to clear off, the half-life was much more compared to the other drugs. But this this study had shown that it has its own complications, vitreous hemorrhage, retinal detachment, because they had injected at a site which was around 2.5 millimeter from the limbus. Whereas we have seen that the babies pars plana don't develop that early, so we have to inject at least 1 to 1.5 millimeter from the limbus is the correct site for the injection. Then came ranibizumab, and the Rainbow trial had highlighted the 0.2 milligram dosage of ranibizumab is much better than over the laser therapy. Like the treatment success was 80% in the cases who had taken anti-VEGF, whereas around 66 to 70% were only treated with laser. And again, it is approved by European Union and India for treating zone 1 or aggressive ROP. The latest inclusion in this treatment modality is aflibercept, and 0.4 milligram intravitreal aflibercept found to be equally efficacious as laser. And they have followed up the patients till 24 weeks. Though it is the side effects are almost comparable with that of the laser therapy, both systemic and the local. What are the challenges and limitations of using anti-VEGF? Mind you, these are all premature babies, so they have their own systemic issues. They have a delicate health. Most of them are on incubator. They have underdeveloped immune system, and they need more frequent monitoring and a long-term follow-up. And we don't know what are the long-term side effects of these injections. They have local side effects as well as the systemic side effects. So long-term follow-up is required to find out what are the side effects in these babies. And as on now, there are no proper guidelines or consensus even today. The dosages vary, the site of injections vary, the frequency of follow-up, everything is different. There is no consensus among the practicing retina surgeon or the doctors who are practicing ROP. So there was a study which was conducted by the Indian ROP Society, And it was on a questionnaire-based study to find out what are the practices, preferred practices of anti-VEGF use in Indian setting, in which they had asked what are the indications of injection, and what were the preferred anesthesia used by them, and what was the procedure site and the treatment protocol. In that, most of them are using in the case of aggressive ROP and hybrid ROP, or when there is a persistence or reactivation of the disease, and majority of them were almost 93% of them were doing under local anesthesia only, and the procedure was done. In majority, it was in the OT, and if the baby is not fit to be shifted, it was done in the NICU. And the most commonly used drug, almost more than 50% of them were using bevacizumab. And the follow-up schedule, there was no clear-cut pattern. They were telling as per the severity. So I would like to talk about a word about this safer ROP protocol, in that they have recommended using a shorter needle because the damage to retina will be less, and use proper antiseptic or antibiotic. Like we have to use 10% topical betadine, that is a better choice. And the babies have to be followed up within 48 to 72 hours, and then every 1 to 4 weeks post-injections. I would like to show a few cases which have been managed by us. This child had zone half disease. You can see after the injection, I waited for 2 weeks, I did an FA, and you can see the vessels are not progressive and not cross the fovea in the right eye. So I had to do a laser in this patient along with the anti-VEGF injection. And this was another case. This girl again had an aggressive ROP. She was a 25-weeker with a birth weight of 525 gram. And now she's just started going to school. The mother had sent me the recent pictures of the baby. And the third one is again the present center where I had just treated 4 weeks back. And you see the tortuous, these cases we have to use anti-VEGF. There is no other way out to quieten down the eye, reduce the vascularity, the aggressiveness. To conclude, anti-VEGF has become an integral part of our ROP practice, but we need to optimize the treatment regime and dosage. And as like AIOSSC, along with the BRSI, had taken a stand for the intravitreal injections for adult, I would request we should consider this also into sincerity. And thank you for your patience.
Thank you, Raji, for a very nice talk on ROP and emphasizing the role of anti-VEGF agents. You see, you said 3 anti-VEGFs are approved now. So which one is the choice? Anyone can be used, because how to prepare 0.4 milligram of aflibercept?
That is difficult, sir. I have been using only ranibizumab as of now. Maybe we are in the government setup, and you know the safety. Always there is a fear of infection with bevacizumab when we use, because we have to, again, there is no facility to fractionate the drug. For aflibercept, they are suggesting we use the insulin syringe, sir, which has that minor, again, divisions in that. That can be used. That's what they're recommending. And we don't have a 30 or 31 gauge needle, which are 4 mm in India. Only, I think, one of the manufacturers. It's very difficult to get.
And do you always give bilateral simultaneous injection?
Sir, if there is a bilateral disease and the patient is not well, I do give, sir. Because again, to stabilize the baby, and you know, and we won't get time. Sometimes they deteriorate even during the procedure. They have apneic spells. Then we might have to wait for another couple of days or weeks, then we'll lose the battles.
And do you necessarily take them to the OT, or you can do bedside?
Sir, depending upon again
NICU,
the conditions.
can you do in NICU?
We are doing in some severely acutely ill patients, we do in the NICU, sir, with the neonatologist.
Because what is required is a sterile field, not
yes,
a sterile OT actually.
Sir. So we use a sterile towel to even the baby cot has been sanitized. And
Rohan, any comments about choice of anti-VEGF?
A very nice talk. So like Dr. Raji has already pointed out, because of safety concerns, most of us are using ranibizumab. But like from our experience, all of us know that bevacizumab probably lasts longer and has less of recurrences. But still, we are treating a very premature child and we are doing both eyes simultaneously. Same. So we all want to use something which is approved. So probably that is the reason. We have to use entirely different set of speculum, everything, change the gloves, again, all this thing has to be separate. So that is just a question for you then, ma'am. In your experience, after razumab or ranibizumab therapy in such babies, how much percentage do you still find persistent avascular retina?
So most of them I have treated are on an aggressive ROP or in the zone 1 disease. It's almost 70% of them I had to give.
So then combination therapy has to be done. Yes, I'm just
buying time combination and the vascularization.
Ma'am, have there been instances where you have had to repeat an injection? Or would
Yes,
you just
in
do
3
laser?
babies I have repeated the injection.
And what would
because
be your indication for that?
Again, there was recurrence of the disease. Even after the laser, the last case which I shown, he had recurrence. You know, it was, I was not knowing what to do actually. He got deteriorated further and he went into stage 4A, stage 4, then I had to operate that one eye of that child. You know. So sometime even after all these measures, they won't recover completely.
Thanks a lot.
Thank you, sir.
I thank all the speakers, Brigadier Mishra, Dr. Pradeep, Dr. Poninder, Dr. Raji, and all the panelists for very exciting discussion. Thanks a lot.
With this, I would request Brigadier S.K. Mishra to present memento to our speakers and panelists. First, I would invite Brigadier Vijay Mathur. Professor Lalit Verma. Brigadier Poninder. Professor Rohan Chawla. Dr. Ruchir. Colonel Raji K.
He had best of both the worlds. In fact, मैं मतलब मैं इससे पूछता था, Rohan, how are you enjoying? And after he joined मैंने इससे पहले ही पूछा तेरे को कौन सा अच्छा लगा? इसने कहा नहीं मुझे आर्टिस्ट एक्चुअली छोड़ने के बाद 2 साल मुझे भी लगा मैं आर्टिस्ट सेंटर वापस जाना चाहिए.
Colonel Pradeep Kumar.
Most prized photo. Most prized photo.
I request Professor Lalit Verma to present a memento to Brigadier S.K. Mishra, please. I request all panelists and participants to please come on stage for the photograph. For our last session today, but not the least, on retina, for today I invite our panelists, Professor G.K. Das, Professor Kirti Singh, Dr. Alkesh, on stage please. I request Professor Lalit Verma to moderate this session please.
Thank you. I'll request Ruchi to keep sitting here and also invite RP Singh along with me. It will give me more confidence. RP. Lights, jala de. Can we have the lights? So, last but not the least, I think this is one of the most important session we'll try to have as much discussion as possible. And we have an international speaker for this, thanks to Novartis for arranging this. And the reason I insisted on international speaker was that all of us keep talking about, Dr. Anirudh is online. AV. Dr. Pradeep, can you see Anirudh is online? Yeah. Hi Anirudh, can you listen?
Hello, good evening sir,
Hi.
I'm here.
Hi. So the reason we insisted to have an international speaker, because we keep talking about this new wonder molecule about brolucimab, and in India a lot of us have experience, but there is amongst the general ophthalmologist or maybe amongst a section of people, there is some fear. And the reason we wanted Anirudh to be here because he has a lot of experience of usage of this, I call this a wonder molecule primarily because of the maximal drying effect amongst all the anti-VEGF agents which we have today in the market. This has a maximal drying effect. And somehow you see patients who are resistant, they also respond so well. Patients who have pachychoroid disease, CSR, or chronic CSR, PCVs, or type 1 CNVMs, wherever there is a choroidal disease, because of small molecule 26 kilodaltons, this molecule has ability to penetrate, and hence my feeling is that it should work very well in patients who have type 1 CNVM or pachychoroid or PCVs. And we are very fortunate, very lucky to have Dr. Anirudh from Abu Dhabi, who is in Cleveland Hospital. He was one of us. He is, product of PGI, Chandigarh. And over to you, Dr. Anirudh, for telling us about enhanced treatment outcome with brolucimab, both in NAMD as well as in DME. Anirudh.
Good evening sir, thank you very much for the invitation. So I'd like to thank AIOSSC Scientific Committee, Armed Forces team for having me for this particular talk. So a lot has been said already about brolucizumab and the incidence of diabetes overall. I'll just go through very quickly. So we all know the burden of the disease, so I'm not going to elaborate much. We are indeed grappling with the ever-increasing population of diabetic patients world over. It's just not in India, but world over, also in the Middle East, with millions and millions of patients and newly diagnosed patients. And also those patients with significant disease. We have a significant proportion of patients who present with sight-threatening disease like DME and PDR as a subset of many of these patients. There is an unmet need, definitely from all of our perspectives, from the patient perspective, physician, as well as from the healthcare perspective. And from the patient perspective, I think Lalit Verma sir has already highlighted some aspects that patients have a lot to deal with. They just don't have the eyes, but they have significant other body organs, neuropathy, retinopathy, nephropathy, and other aspects that have to be dealt with concurrently along with the treatment for macular edema. And the quality of life definitely suffers. And because of this, there is a lot of burden on the patients to come to the clinic. They have to take a lot of time out, spend a lot of time waiting in the clinics, and they also require their caregiver's assistance, someone to bring them over for an injection. And so overall, the compliance for patients, especially diabetic patients, in receiving injections is much lower compared to neovascular AMD. So this particular study in the US and Europe shows how there are significant number of no-shows, patients not attending clinics, especially diabetic patients with lots of cancellations also. In fact, I think in Cleveland Clinic in Abu Dhabi, we have about 30% cancellation or no-show rate in patients who are scheduled for injections with diabetic macular edema. So this is definitely a challenge. And this is because of multifactorial reasons. In India also, I think you see a large chunk, in fact, a majority are non-compliant. Less than 50% are patients who are compliant. And if you look at the others, like in the US, is no better, in fact, probably worse. And a lot of patients have complaints of long waiting times in the clinic or other physical or mental conditions or medical conditions. And so they're unable to get leaves, unable to, you have young patients now with macular edema. And so this is definitely a challenge. In general, you see that if the patient does not follow up it has a direct effect on the visual acuity of patients. And so, as much as you want the patient to have a regular follow-up, we want treatments which are long-standing so that you feel safe in sending the patient home without anticipating a significant loss in vision. Let's say the patient doesn't come back for a few weeks. So from the physician's perspective, if you survey all the physicians, this is an ASRS survey, but this is, I think, true for all of us. When we say that our main priorities today are fewer injections, reduced burden, and long duration of action. This is what we all want from the injections. Apart from that, we also want the injections to be more effective. We think that efficacy and safety are our primary concerns. So we would want injections which are safe, effective, long-lasting, and they are capable of reducing the patient visits. From the healthcare perspective, I think with millions and millions of patients developing diabetes and related complications, it is a burden on all of us. It's a disease burden. It's greatly utilizing the healthcare resources. And you see the total number of healthcare visits are going to exponentially expand in the next few years, especially patients with diabetic macular edema. In India especially, I think age-related macular degeneration is still not so much of a problem as is DME. And so, moving further, this leads to administrative challenges, clinical challenges. We are overwhelmed with patients in the clinics. We don't have time for research. We don't have time to look at tools such as OCT very carefully. We don't have time to look at OCT angiography, and majority of our clinics are so busy. And so, if I summarize, the multifactorial nature has to be dealt with very strongly. So we have the disease burden, we have issues such as non-compliance, healthcare utilization, and also suboptimal vision gains. And on top of all this, these are key obstacles in really achieving the visual acuity, the restoration that we're looking for in patients of DME. So brolucizumab is definitely one of the newer anti-VEGF which we use in our clinics very regularly. And I resonate with what Lalit Verma sir said a few minutes ago, that with increasing use of brolucizumab, our confidence in the molecule has really gained in the last couple of years. Compared to aflibercept, you see in the KITE and CRESTAL study for DME, I was a part of KITE where PGI was a center, and I was the injecting physician for brolucizumab. And really, I think in DME, it works very well. In comparison with the aflibercept, you see the visual acuity data with brolucizumab is very consistent with aflibercept that you see, in the primary outcome measure at up to week 100. They were comparable to aflibercept. The mean change in CST, and this is the highlight of the molecule, it's a very robust response to brolucizumab. And the reduction in the macular thickness is immensely better compared to other agents. In the clinical trial setting, you see also the response is superior. It's not statistically different, but you see that it's comparable to aflibercept, but in numbers it is slightly better, and that's what we also experience in real-world data. So, more brolucizumab treated eyes have achieved really the macular thickness of less than 280 up to week 100, despite lower number of injections. So here you have comparison of 11 injections versus 15 injections up to week 100. So there's a lot of difference in the number of injections, and I think each injection adds treatment burden in these patients. And fewer patients will have persistent intraretinal or subretinal fluid. I think this is highlight again of these newer anti-VEGF, especially brolucizumab. The anatomical response is the highlight, and it does translate into visual acuity improvements also. And you see that you have almost 50% patients who are going to Q12 interval, so every 3-month interval, and at least 70%, 67 to 70% patients having a Q8 interval. And this is a very, very good response. And if you have a patient where you can, be rest assured and don't have to inject every 3 months or earlier than that, that's a very good, rate as well. And of course, in both the studies in KITE and CRESTAL, okay, so the brolucizumab number of injections were much less compared to aflibercept. This is just a tabular data to show you the same. Safety profile in DME, we have really not seen very alarming intraocular inflammations or safety signals. It's a different story for AMD maybe, but also that too in certain risk population. In DME, in the clinical trial data, you see that there is no significant difference from aflibercept. And actually all anti-VEGF agents are responsible and can cause intraocular inflammation. We'll talk more about this, I think, when we have our discussion. But let's look at some of the real-world cases. So I do use brolucizumab as a first-line agent in treatment-naive patients. And usually when it is a treatment-naive patient, I encourage you to use brolucizumab. And when you do this, you will see that you cannot complain. The response is very good with the agent. And you see that over a period of time, as the patient receives more and more injections, the anatomical response is very good. It is an effective first-line agent. And you see also it has very good effect on anatomical factors such as hard exudates. So this patient who had center-involving edema went on to receive aflibercept. But you see, look at the response. There was some increase in the hard exudates, and this is slightly concerning to us when we're talking about subfoveal migration of hard exudates. So before the advent of the brolucizumab, I would have preferred probably a dexamethasone implant in this particular patient. This is what happens after aflibercept. But the moment you inject brolucizumab, you see it completely disappears. Before brolucizumab, probably I would have relied on dexamethasone implant. But now with brolucizumab, I think the anatomical response definitely is very good with brolucizumab. So it has a favorable response on hard exudates. It does have a favorable response on non-favorable OCTs also. When you have a chronic edema, when you have very thinned out pillars of the inner retina separating the large cysts, even in those situations, brolucizumab works very, very well. This is another patient here. As you see, the visual acuity to begin with was 21-25. I think this is one of the examples where the OCT is not very favorable to begin with. You have lots of cystoid spaces and you have hard exudates, hyperreflective foci, and thickness is more than 436 microns. As the patient receives further injections, you see a gradual improvement in visual acuity. So you see the patient has improved to 20/80, 20/60, and the interval has increased almost to 7 weeks here. And the macular thickness is now just above 300 microns. And at this point, after the 4th dose, the macular thickness comes to 286 microns and visual acuity improves to 20/60. So as you go on persisting with this particular agent, you see you have increased the interval to more than 12 weeks and you are maintaining the visual acuity to 20/40, 20/50. And I think this is a very good response if you compare what we began with, and the macular thickness is indeed favorable. Of course, this is a continuous journey. There is no end to the journey of diabetic macular edema, but as long as you can increase the interval, that's very satisfactory. This is another example of a patient with intraretinal fluid. This is a combined situation here where there is pachychoroid as well, and there is a choroidal neovascularization. So just one case of AMD here, showing you this kind of a membrane here on FA and ICG. This patient was a long-standing case where ILIA was given in 2016. And look at the OCT, it is definitely a non-favorable OCT. And there was really no response to ILIA. You see the macular edema, the intraretinal fluid persisted. This is in 2017 and beyond. You see, despite many injections of aflibercept, there was not much anatomical response. And the reason why persistence of injection was done was because the visual acuity, he noticed a subjective improvement from 21/25 to 2100. So the ophthalmologist did not want to give up on the injection. They even tried PDT at some point. And this is after PDT. The intraretinal fluid really did not resolve. In 2021, the patient was also given a few injections of ranibizumab, then aflibercept. Nothing happens. The edema stays. And you see that this patient was about 21/25, 21/50 at this point. And, with one shot of brolucizumab, this is how the patient is. And at this point, it's not just the anatomical response, but the visual acuity improved to 20/80 from 21/25. This really gave a lot of encouragement and hope to the patient. And since then, this is now 2022, and it's almost 1.5 years since I took this OCT. this patient is continued on brolucizumab every 3 or 4 months. So the key obstacles really are to overcome in the management of DME are to reduce the treatment burden while maintaining the visual function in patients. And with newer agents, brolucizumab, I think, has sustained the test of time. It does provide sustained vision gain with less number of injections. In DME patients, I'm not really worried about intraocular inflammation. It has a well-tolerated safety profile in DME patients with long-term no side effects or safety signals. And with this, thank you very much, and I'm happy to take any questions. Thank you.
Thank you, Ruth, for this very nice talk on primarily DME and only one patient of AMD. The highlight what I could gather was, compliance and compliance. Because with the conventional anti-VEGF agents, you listed a lot of things about repeated visits and waiting time and cost and so many other things. I agree with you that if the compliance is good, then the treatment effect is also good. And once the treatment effect is good, whether anatomical and which translates into visual also, then patient's confidence also increases and surgeon also feels better. So that is one issue with which should go in favor of this longer acting agents. And other was about why is the difference between, say, you said adverse effects in DME is not much compared to ARMD. Could you elaborate on this? About the
Yes,
about the
so
IOI part.
if you look at the clinical trial data,
The reason I'm asking is
guidance-
because the reason I'm asking, Ruth, is because you see a lot of people in India may not use this as a first line of treatment.
So I would refer to one of the study, which was a Japanese study in neovascular AMD and DME eyes. They collected a large set of patients who had intraocular inflammation from brolucizumab. And really the risk factors that were identified in those patients were advanced age, patients more than 80 years of age. AMD was a risk factor for inflammatory complications from brolucizumab. For some reason, diabetic patients have a protection from intraocular inflammation. They don't show IOI as much as other subset like AMD. There could be a number of reasons for that. In general, diabetic retinopathy is protective. We don't see many patients with concomitant DR and uveitis or retinal vasculitis together. It is a difficult topic, controversial topic, why this happens. We don't have exact answers. But I think this has something to do with the pathophysiologic changes that happen at the microscopic level. They are probably protective from the intraocular inflammation from biologic agents. The risk factors definitely are high age, previous uveitis. So I heard, I think Dr. Mishra earlier say that we have to be cautious. And I agree, you have to be cautious, and in general, I do not inject this agent in previous cases of uveitis. If a patient is very elderly and has neovascular AMD, I'm a bit careful. In DME, I don't have that consideration, I do inject. I don't do a routine fluorescein, or I don't do any screening of any kind to look at inflammation before I inject brolucizumab. I use brolucizumab in one-eyed patients also in monocular. My standard protocol is to call them after 4 to 6 weeks. I don't call them the next day or 2 or 3 days later.
So that was the other question I wanted to ask. Sorry,
Yeah.
the reason, because you touched upon the follow-up. What is your usual follow-up protocol in say if you have injected brolucizumab vis-a-vis say aflibercept? Follow-up protocol with both is same?
It is the same, sir. I don't make any changes here for brolucizumab. What I do is I try to call them in 5 to 6 weeks after the injection.
And the other two more questions before we go to
Yeah.
Dr. Ruchir for the next talk is how frequently are you using in as a first line treatment naive patient? Patient has come to you for the first time, DME, a non-tractional, center involving. So what is your choice? Is it the first generation anti-VEGFs, or you start with this newer anti-VEGFs?
Yes, I think I use newer anti-VEGFs now as first line. I am, I think, blessed because I have an insurance-based practice, so cost is not a consideration. But the moment I see any patient with severe macular edema, unfavorable OCTs, treatment naive patient, I would like to start on brolucizumab. I would say 1/3 of my new patients will be on brolucizumab. 1/3 will be on another agent, faricimab probably, and 1/3 on, we have the new ILIA now, ILIA 8 milligram. So I'm trying the ILIA 8 milligram also in a large number of patients.
So I think you are the best person to tell us if 1/3, what is the effective response in between two of them. I am forced to ask this question because because Dr. R.P. Singh is sitting with me and he is also asking the same question. You yourself have committed 1/3 brolucizumab, 1/3 faricimab, and 1/3 HD or high weight. So what is the
answer?
Yeah.
Before Anirudh, you answer this, like I have a friend in UK. So there they are primarily using more of ILIA 8 milligram as compared to the brolucizumab. So do you find the European conditions, that population, they are more have IOI as compared to the ILIA? Because
So the Europeans are not using.
Their first preference is more towards the 8 milligram ILIA now.
The reason Europeans are not using brolucizumab is not because of intraocular inflammation. This has to do with insurance and reimbursements and nothing to do with intraocular inflammation. And so brolucizumab is sparingly used in Europe. But really that I don't use that as a guide to practice. That is not the reason. They don't have an extra inflammatory response compared to us.
No, let's come to the question straight away, that efficacy wise, the drying effect, because that is what we want to hear.
I think ILIA 8 milligram gives you a response which is longer. I think 16 weeks, Q16 weeks is definitely possible with 8 milligram, 4 months to 5 months interval. The next would probably be brolucizumab, which gives 3 to 4 months. Faricimab is only, I think, 1 week more than ILIA. Honestly, I'm slightly disappointed in faricimab. I'm, happier with 8 milligram ILIA and brolucizumab.
Okay, the last question, Ruchir, you can be on the podium, is you touched upon Ozudrex actually. And today, suppose a patient on aflibercept or any other anti-VEGF is not showing adequate response, is your choice, suppose you are making switch treatment naive we have discussed, switch patients, will you prefer brolucizumab or you will prefer Ozudrex?
I think it has tilted towards anti-VEGF, towards brolucizumab.
Why
so?
So?
I would rather use one of the newer anti-VEGF agent.
No, once we talk of newer anti-VEGF, let's be very specific, because you see, newer means in India, we don't have HD, we don't have 8 milligram as of now. We have a choice of faricimab, we have a choice of brolucizumab, and we have a choice of steroid. In DME we are talking. So DME, which one do you want us to, prefer?
If the OCT is unfavorable, if there is a chronic DME, lot of hyperreflective foci, then brolucizumab. If it is a clear-cut cystic edema, not responding very well, then faricimab.
Okay. That's so steroids are on the way, on the decrease frequency with coming up with new
unfortunately, yes.
Yeah,
I think they are more useful now post cataract surgery or uveitic edemas.
Agreed. This was discussed in the previous session also. I don't know whether you were online or not.
I heard your talk, and the cataract surgery DME.
So that's what, this may, I agree with you that once it is cataract surgery and DME, then Ozudrex may be a treatment choice. But otherwise, I think there is a tilt, there's a definite tilt towards brolucizumab. The difference
and
I
in
find.
vitrectomized eyes.
Correct. The difference I find between faricimab and brolucizumab is the wow effect. Because brolucizumab gives a very big wow effect.
I totally agree, sir. When you said that wow effect is, I think that is there only with brolucizumab.
Yeah. Okay, thanks Anirudh for this very exciting talk. But I would request you to be with us for another 10-15 minutes because we'll wind up the session because there may be a lot of questions which may come up. Thank you so much.
Sure, thank you.
So we'll now have Ruchir Tiwari, who is young, energetic, very dynamic, but has a lot of experience on this newer anti-VEGF, and he will tell us about the drying and durability part, the 2Ds. 2Ds, what we talk.
Thank you, sir, and thank you, Brigadier Mishra and the RR hospital team for giving me this
Ruchir,
opportunity.
primarily examples. We will not go into literature at all.
Yes, sir. No. So, there's no financial disclosure. So this is how I started my journey with brolucizumab. This is 4 years back. with switch cases, difficult situation, non-compliant patient, non-responders, then to switch and then to primary patients, treatment naive and treatment optimization. And finally, when it was approved for DME, I started using it in DME as well. So I'll skip directly to the cases. The first patient is a one-eyed patient. This is actually the first patient that I injected this drug in. He's an 83-year-old gentleman, BCVA 6.9 in his left eye.
A different presentation.
That's mine. Right eye had old retinal
Come to
detachment, PL negative.
Achha,
He first presented in September 2020. Fundus showed a drusenoid PD in the left eye, and a conservative approach was followed. So this is the first OCT of the patient. This is the drusenoid PED, but the vision was 6.9. There did not seem to be any fluid. Patient came back 4 months later. BCVA had decreased to finger counting close to face. The fundus showed a large macular detachment. This is the OCT from that time. The patient had developed a large RP rip along with lot of subretinal fluid, and the OCT picture clearly shows why the vision was finger counting close to face. So plan was at that time to give loading doses of ranibizumab followed by treat and extend. Patient was non-affording for aflibercept, and at that time not all centers were being given the ILIA for You program. After first injection of ranibizumab, nothing much had happened. BCVA was still finger counting close to face, so I switched the patient to brolucizumab. This is 4 weeks post brolucizumab, when most of the fluid had gone away. BCVA had improved to 660. At 8 weeks, all the fluid had gone away, and BCVA improved to 6/24. And this is when the second injection was given. 6 weeks, the patient was fine. He came back after 13 weeks. Again, there was a recurrence, and BCVA dropped to 660. 6 weeks later, brolucizumab injection 3 patient is again doing fine. 4th injection was given at 12 weeks. So how has this patient fared over a 3-year period? This is the last OCT that was taken before giving the last injection. The patient has up till now received 15 brolucizumab injections over the past of 3.5 years. He's maintaining on a 3-4 monthly injections basis. Although the BCVA has gone down 1 line, but the patient is still able to manage all things by himself. The second case is a very non-compliant patient, a case of occult CNV, 78-year-old gentleman, blurring of vision in the left eye for 2 months. BCVA right eye, 6.9, left eye, 6/12, pseudophakic both eyes. These are the fundus images, and this is the angiography image, which shows a late leakage in the left eye. These are the OCT images from the first visit. The left eye clearly shows mild SHREM and an altered RPE. Although when we look at the above scans, there is a lot of subretinal fluid which is not seen in the subfoveal scan. Patient was given 1 ranibizumab injection. The patient disappeared for a year. He came back in Feb of 2020, exactly 1 year later. BCVA was 6/12 itself. Fluid had increased. So second ranibizumab was given to the patient. The patient again disappeared for a year. Then he came back in Feb of 21 with a sudden decrease in the vision in the same eye for the past 2 weeks. This is the OCT from that time. So you can see that there are all the negative prognostic OCT biomarkers that you can see in the OCT picture. Lot of subretinal fluid, lot of SHREM, large PED, lot of hyperreflective foci. So at this point in time, I shifted the patient to brolucizumab. This is 4 weeks later, when most of the fluid had gone away, all the subfoveal SHREM had gone away, and there was a little SHREM still left. BCVA had improved to 6/24. Follow-up. This is 4 weeks, and when the patient came back after 12 weeks, again there was a disease recurrence. As I mentioned, this is a very non-compliant patient. So 4 weeks later, there is increase in visual activity. At 6 weeks, the visual acuity improves and the OCT also improves. So this patient has been receiving regular brolucizumab injections. After 3 years, he has developed neovascular AMDs in both his eyes. Now the right eye has already received 7 brolucizumab injections. Left eye has received 13 brolucizumab injections, and he's maintaining his visual acuity well in both his eyes. The next patient is a recalcitrant disease. She is a 60-year-old female, decreased vision in left eye. She had already received 3 ranibizumab monthly injections followed by an aflibercept. Her BCVA in all this duration did not go beyond 618. Last injection was given 3 months back. This is the OCT from that time, which shows a well-demarcated membrane complex along with SHREM and subretinal fluid. I re-injected ranibizumab. So 2 weeks later, there is a slight decrease in the SRF. BCVA is 618. 4 weeks later, there seems to be an increase in the SRF again. So I shifted the patient to brolucizumab because she had not responded to aflibercept either earlier. 4 weeks post brolucizumab, all the SRF goes away, and for the first time, patient's BCVA reaches 6.9. 8 weeks post brolucizumab, she again has a recurrence. Vision goes down to 6/12. Second injection is given at this point in time. So she again has a very stormy course. She has received 14 brolucizumab injections over the past 2.5 years. Last injection was now given in November 23. So more or less a 10-month disease-free interval she's had. She comes for 3-monthly follow-up, and her vision is now 6.9. The next patient is a very interesting situation. This is a 40-year-old female working mother, pachychoroid with type 1 CNV. I first saw her in October 19, and between October 2019 to September 21, I had to give her 14 ranibizumab and 2 aflibercept injections. The best part was that her vision was still 6.9. So this is the the fundus photo and the OCT picture and the angiogram. This is September 21 with BCV of 6.9 when the patient had the last recurrence. I shifted the patient to brolucizumab. I was following her monthly just to find out when the recurrence is going to happen again. So this is December 21, January 22, Feb, March, April, May, July. Finally, after 1 year, she had a recurrence when she received her second brolucizumab injection. So this patient has been, this is September 24, this month's OCT. Patient has been disease-free for a period of 24 months now. Her BCVA is 6.6, and she's still on a 3-monthly regular follow-up. On to some treatment-naive cases. This is a 72-year-old female, BCVA 6.12 in the left eye. Right eye already had a macular scar. Left eye showed a membrane complex superior to the fovea, SRF in the subfoveal region. Because the foveal region was actually clear of any membrane complex, after 1 injection of brolucizumab, she regained her vision to 6.6 parts. After 2 years, she still maintains her BCVA to 6/12, and she has received 6 injections so far. And she's on a 2-monthly follow-up. The next case is an 82-year-old lady. So she was a case of dry AMD, which gradually progressed to neovascular AMD in both her eyes. She has received a lot of injections, and within 2 years, a total of 13 injections, 7 in the right and left in the left. Her BCVA is 660. She's still able to manage all her daily works. The next patient is a treatment-naive 66-year-old female, diminution of vision for 1 year. BCVA was finger counting close to face. If you look at the OCT, it is not looking very good. There's a lot of Schrem and a lot of scarring in the macular region. Her baseline visual acuity was finger counting close to face. She had not received any treatment before this. She got 1 injection brolucizumab. 12 months post-injection, her BCV improved to 660 with no recurrence in this eye. She did, so a 3-year post-stop of this of the same patient is 3/60 after a single injection of brolucizumab. She unfortunately developed neovascular AMD in the other eye, and in the last 2 years, she has received 8 injections so far on a more or less 10-weekly regimen. BCVA remains 6.9. So DME was the next thing that I gave the injection to the patients to. So this is a 60-year-old female, BCVA 6.18 and 6.9 in the right and left eye. She had early nuclear sclerosis both eyes. Fundus shows dull FR in both her eyes. Right eye shows center involving DME, and left eye shows mild non-center involving DME. In May 22, she came back. Her BCVA was 6/18. In the meantime, of these 4 months gap, she had received 3 ranibizumab injections, 1 aflibercept, and 1 ozurdex in the right eye over last 1 year. Her A1C was 6.7. So she had received all possible treatment that she could for this particular disease, but nothing had worked. I gave her 1 injection of brolucizumab. So this is July of 22, 2 months later. BCVA is still 6.18, but the CMT has gone down. At this time, I inject brolucizumab again. In August, her vision improves to 6/12, CMT is 276 microns. She came back 1 year later, and still there was no recurrence of disease. In the meantime, so again, right eye, December 23, vision is the same, and CMT is normal. In April 24, in the meanwhile, she developed macular edema in the other eye, and she received another injection, the same injection in the left eye as well. So this case is a 65-year-old lady, mild cataract and non-fovea involving DME, both eyes, December 22, right eye 6'9", left eye 6'9", good systemic control. She was kept only under observation. The patient lives far away. She came for follow-up after 4 months. And in the meantime, cataract surgery had been done in her left eye, which was performed elsewhere. She had, the vision had dropped down from 6'9" to 6/24, I think what we were discussing about cataract and DME. She had received 3 monthly ranibizumab injections, but there was no improvement in her vision. So looking at the OCT, I performed an angiogram. I found few leaking microaneurysms which were near the fovea. So the plan was to give 1 brolucizumab injection followed by focal laser. This is June of 23. BCVA is 6'9", and CMT has gone down to 230. The next case is a 60-year-old female, decreased vision in both her eyes, diagnosed severe NPDR and DME, 6/36 BCVA in both her eyes. So she was a CGHS beneficiary, and at that time brolucizumab had been approved in CGHS. So I thought of injecting her with brolucizumab. These are the initial OCT images, and this is post-op after 3 weeks in the right eye and after 1 week in the left eye. Now this lady had a recurrence after 6 months, and in the last 1.5 years, she has received 3 brolucizumab injections in both her eyes so far, at 6 monthly interval, and her vision has improved to 6/12 in both her eyes. The last case is DME and PDR. So generally, if there is not much DME, I would not inject, and if there's not much bleed, then I would not give an anti-VEGF before doing PRP laser. But so this particular patient came, 65-year-old female, decreased vision, BCVA 6/36 both her eyes. She had mild vitreous hemorrhage and PDR in both her eyes. So if I look at the OCT, there is mild neurosensory detachment in the right eye, and there is generalized thickening of the fovea in the right eye as well. So instead of giving ranibizumab, I thought I'll give brolucizumab to this patient, followed by a full scatter laser. The same plan was followed. 3 months post-treatment, her BCVA improved to 6/12, and she did not develop any edema later on. I've been following this patient for a year, and she's not received any further injections. The last patient is a 44-year-old male, sudden decrease in vision in his left eye, diagnosed with bilateral PDR with left eye vitreous hemorrhage and cataract, and right eye pseudophakia. BCVA was 6'9" and hand movement at presentation. Received injection ranibizumab in the left eye and full scatter in the right eye. This was followed by cataract surgery in the left eye and full scatter. In Feb 23, 2 months after the initial treatment, he developed DME in the left eye. BCVA was 6/18, right eye was doing well. In March, BCVA was again 6/18, so I gave an injection again. The CMT was 408. 1 month later, the CMT increases to 554, so I changed the drug to brolucizumab. In July, vision improves to 6/12 with a significant reduction in a CMT. This is 1 year later. This is the last OCT taken 2 weeks back when the CMT has
shall we
gone
summarize,
down further.
Ruchir?
Yes, sir. So I've used more than 550 vials so far. I've used it in all possible indications. This is my first-line agent for all the approved indications, and I've had no cases of intraocular inflammation encountered yet. So if I were to summarize, the crux of my 4 years would be that this molecule has very increased longevity, which means fewer injections, decreased financial burden, and as Sir has already pointed out, increased patient compliance. So patients do seek treatment with this newer drug. Thank you.
Thank you, Ruchir. I think you have one of the largest experience of usage of brolucizumab and virtually all the indications. You see, like rightly pointed out by Anirudh also and by you also, the beauty of this injection is compliance and reduced number of injections. Only 2 cases I think caught my attention. One was the patient who had 40-year-old pachychoroid disease, and she had a recurrence after 1 year. Any comments on that? I'll ask Anirudh also to comment on that, because she did not require for last more than 12 months. And second was this patient of cataract surgery. We did discuss with Anirudh also and previously also. And today, is there a shift? Again, I'm asking the same thing. Is there a shift towards brolucizumab from steroid?
Okay. So taking your first question.
Can we have Dr. Anirudh also on the line? Yeah.
So the pachychoroid lady who had a recurrence after 1 year, I think one of the reasons is that generally also more or less a CNV would be there for 5 to 6 years duration. This patient had already received a lot of injections over the past 3 years. And when a newer drug came which was more potent, maybe that is why she did not require any further injections for a period of 1 year. And after that, when she received it, she has now been on follow-up, and it's been 2 years and she has not received any injections.
Anirudh, any experience on such pachychoroid spectrum?
With brolucizumab, sir, I have limited experience, but in general, the pachychoroid spectrum CNVs, they do respond to brolucizumab. I think the response to the BVN is much better, but the polyp closure rate, I think, remains the same with all anti-VEGFs.
Yeah, you don't expect also, honestly speaking, how can you polyp close? You see, polyp can become inactive. That's it.
Yes.
The other factor was about the usage in PDR. I would not actually, you see the example which you showed, first patient of PDR with minimal diabetic macular edema. I would have done the reverse actually. I would laser first and then give, rather than, you see, starting with brolucizumab. Because firstly, PDR patients, I'm slightly scared of any traction anywhere else also, because it's a very potent molecule. Sometimes there's a fear of precipitating a crunch phenomenon or TRD in such patients. We have seen in other anti-VEGF agents, and in specifically this patient which you showed, because PRP may increase the macular edema also. So I'll first secure the retina with PRP, and then maybe give brolucizumab. Yes, Anirudh, your take.
I agree with you, sir. I think we should secure, especially in such cases where you can have some focal tractions here and there. Better to do some, at least put in some laser PRP, and then maybe in the before the second sitting of PRP or something, you can plan maybe anti-VEGF.
But thanks a lot, Ruchir, for showing so many examples and a lot of experience, using variety of indications, and more than 550 injections you have given with no IOI at all.
No, sir.
So, Anirudh, any guidance on patients who may develop IOI, or how to?
Yes, I would say high risk in patients who are more than 80 years old, with neovascular AMD, with previous inflammation from other anti-VEGF, history of uveitis, and any peripheral vascular disease. I think these are patients of high risk.
And how do you counsel these patients? Like, suppose despite all these things they develop IOI, how do you approach? Or
so in general, I just before I inject, I say that there is a slight risk of intraocular inflammation with all agents, probably slightly more in this age group with the brolucizumab, and so I would like to see you maybe in 3 or 4 days after. And once there is IOI, I counsel them that unfortunately you have had this sort of side effect, and we need to keep you under close observation. And the chances are that you will resolve without any loss of vision. You will come back to the normal.
And suppose suppose this patient requires another anti-VEGF, would you go ahead with brolucizumab, or will you shift the drug?
No, so then if the patient requires re-injection, then definitely I will not do brolucizumab. I think the company also advocates that don't use it. And so then in that case, I will go to my trusted, like Eylea, 2 milligrams Eylea.
And suppose the patient does not respond now to Eylea? The reason I'm asking you is a practical example, because there have been, at least 3-4 patients with us where patient was on aflibercept, didn't respond, shifted to brolucizumab, IOI, again shifted back to Eylea, did not respond, again shifted back to brolucizumab, and response again occurs. That is the reason.
This is AMD, sir?
Yeah, AMD. Yes.
For very difficult cases, sir, sometimes steroids work. Off-label use of Ozurdex or off-label triamcinolone may work in patients who are who have lost all response to anti-VEGF. Sometimes you have to try Ozurdex or triamcinolone. That's the only option.
You see, even at LV Prasad, I heard that Dr. Raja Narayan, gave 3-4 examples of patients who did respond to brolucizumab, and because of IOI shifted back to aflibercept. But again, because of the response, they had to shift back to brolucizumab.
Yes, these are all difficult situations.
I know. So thanks a lot. The last talk, Anirudh, another 5-10 minutes only. This is by Dr. R.P. Singh, which is the logical original biologic. Because in this era of biosimilar, when every other company is planning to launch a biosimilar ranibizumab, where does this original stand? R.P.
Thank you, sir. And I'd like to thank Brigadier Mishra and AIOSSC for this opportunity.
Before RP, may I ask Dr. Kirti, because Kirti is heading a very big hospital, GNEC, how is the usage of brolucimab in your hospital?
Sir, I have a question. Hearing all this, I wonder, is ranibizumab already out, or it's only Broly and Fari? Because we don't have either two. Because we don't have insurances, patients don't have, so whatever the supplies from CPA come, it is still Avastin.
See, that so is what probably...
The answer to this is, you have heard the story of Nokia and iPhone. You see, where is Nokia now? You see, the thing is, what I am saying is, because, you see, I had first Nokia, we had all Nokia. Now, majority people have iPhone. What I am trying to say is, we have to move with the changing times. You can't stick to the... I am not saying... let me finish. What I am saying is, nobody is against, Avastin or ranibizumab or original or biosimilar. Question is patient demand today. Question is increased duration. Question is reduced visit. Question is reduced cost. That is and question is wow effect of potency also. You see, if there is a new, therefore all of us shifted. Nokia did not improve its,
to some extent,
thing,
I will
and
answer
therefore iPhone
in my
became.
talk. You might get a little answer of that. And
let's
yeah. So second thing is that as for the masses, definitely we always need some drugs which is cheaper and effective and safe. But as the time moves, as the sir says, that once you keep on getting the better molecules, with the time their cost also becomes cheaper. When we started with the Eccentrics, it was costing almost 80,000.
Absolutely, RP. I think so all of us need to try everything, and then
we
whatever is best for the patient, you should give that.
Yeah. So whenever we are counseling, like I am in a pure private practice setup, so you don't know what patient can afford or not afford. First you see clinically and offer him the best which is possible. And then you go to the finances, what is his affordability and all. So in practice, we take the picture in toto and do the best. So as a clinician, logically you have to offer the best. Tomorrow he might come today, okay, why didn't you offer me this? Many times this happens, you think that patient cannot afford, and tomorrow he comes back, okay, why didn't you offer me this better?
Let's RP, listen to your talk first, we'll come to this question later on. But my advice to, all the GNEC stuff, because you are heading because the Army Hospital, RNR, they have tried so many molecules, so should you and your retina department also. Let's RP, listen.
Now, coming back to the ranibizumab molecule Eccentrics, whether this is the original biological molecule for the retinal disorders, there is no financial interest in this talk. Now, there is always a debate, is that how similar the biosimilars are with the innovator molecule. We know the innovator molecules, they are expensive, so there are a lot of biosimilars into the market, and they have brought down to the cost to a significant level. And is that just the medication cost or the direct cost to the matters? So all these questions over the period we need to answer to the patient. Now, what is a biological product? It is basically a large complex molecule which is produced a very tough biotechnological system through the different microorganism, plant cells or the animal cells. But once you have the genetic product, it gives the same characteristics, same safety and same efficacy over and over. The biosimilar is close to that. So in the manufacturing process, what you have is the target DNA. You develop the specific gene sequence, and once it is developed in the plasmid, you can reproduce that. It goes to the a tough production kind of a thing. Whereas the biosimilar is basically the reverse engineering to the DNA sequence, where the basic genome system is not known. So you cannot reproduce the same efficacy and safety in the same production line. When you get the approval, the government FDA approvals for a molecule which is innovator, you go through the process which is globally it is same in all the world. Whereas for biosimilars, they are different in the different countries according to the needs. So to go through the approvals, you have to have the analytical studies, animal studies, clinical studies before you go for the approvals. But once the innovator is approved, then the biosimilar doesn't have to get approved for each indication. Suppose the Eccentrics, the ranibizumab has been approved for the CMVM, DME, AMD. The similar biosimilar will be approved simultaneously for all the without going through the rigorous clinical trials or the datas. But once we use a large volume of the biosimilars, there's always the immunogenicity and the safety is always a concern, because it can induce an immune response resulting in either loss of the efficacy, then the development of the neutralizing antibodies to the native endogenous hormone, and decreased potency in the subsequent question. So the adverse drug reaction can happen, and in the earlier time when the ranibizumab biosimilars were launched, there were a lot of case reactions which were published in the initially. So you can never be sure of the efficacy of the biosimilars. But now a large volume of these patients, the number of the injections, the vials has been used, and in all scenarios we are seeing that it can be used alternatively. Now in the real world evidence from the India, the large study has been done in the Disha Eye Hospital, in which they have retrospectively studied the from 2015 to 2019, about 19,000 patients, and they divided their cases in the DME and the AMD cases. And they found that the innovator has the 1.6 times more potent as compared to the biosimilars, and almost 1.7 times in case of the more than 3 lines improvement. In case of the DME efficacy, the visual improvement was much higher in case of the innovator injection as compared to the biosimilars, and that also lead to the more compliance. Now when we talk about the overall impact, the financial impact, there's a huge burden of the patients with the DME advancing age, with the NAMD patients, RVOs patient, in which these indications are there. So the compliance loss is not only because of the affordability, but it's not only the cost of drug. Once you have the cost of drug which is involved, there is a cost of procedure, cost of diagnostic, cost of travel and stay, the attendants accompanying the patients. So here the question what the ma'am has asked, the cost of drug is same, but the other, so it can vary. The innovator may be costlier, the biosimilars may be cheaper, but the other cost factors remains the same. Now most of these patients, they have the comorbidities. If you have an NMD patient, he is advancing age, there are age associated other problems. He is a diabetic patient, DME, then he has associated like nephropathy, renal problems, nephropathy or neuropathy. The other association like hypertension, obesity. So he has the comorbidities which he has to spend a lot of money for that. Now the cost can also vary according to the drug regime which we are following, the doctors which follows to the patient, whether it is a pro rata basis, treat and extend, monthly injections, or 12 weekly depending on the result of the disease. And we all know this anti-VEGF, they make a huge potential to improve the visual outcomes. But in India, where the patient has to pay from his own pocket, not all patients can have the government facility or the insurance facility, because majority of the 70 to 80% of the population, they pay from their own pockets. The cost becomes a major factor. So we can have a cost calculator. When we see the patient, there is a basic step in which you can devise a method in which there is a direct medical cost, non-direct, non-medical cost which is involved, the evidence-based appropriate treatment which is required for the patient, out of the pocket where the patient is paying from the insurance company or from the government agencies. So you can design a formula, and according to that you can select the patient, you can fill how you are planning for the treatment, the number of injection, number of years the patient is going to plan for the treatment. And then if you see the difference of the cost, actually at the end of the treatment which you have designed is not much in present day between the innovator and the biosimilars. The cost of the difference is just about 10 to 20, 15,000, whether it is a ranibizumab original molecule or the biosimilar or the bevacizumab. Though the bevacizumab is still the lot cheaper as compared to the biosimilar to the ranibizumab. But with this little cost, what you get is additional compliance and the more effectiveness. The patient requires less number of injection, and thanks to the patient support program now the companies are offering, they get 2 vials free after 6 vials. The effective cost comes much lesser. So with the Eccentrics, what you have is a well-researched and developed, which is many studies and the number of patients which has been injected. As compared to the biosimilars, there are very few studies with the very few numbers of the patient in each studies which is there. So with innovative molecule, what we have is the optimum risk benefit, lesser, shorter and long-term complications, better anatomical and visual outcomes, and the limited difference in the net cost. Thank you very much.
Thank you, RP. I think time is not on our side, but we haven't taken a lot of time. We were given half an hour late, so we have concluded in time. So Anirudh, yeah, I will. And Anirudh is online because Anirudh,
yes.
do you ever use biosimilars there, or what is your take on biosimilars?
We don't have anti-VEGF biosimilars here, sir. We cannot use them. So I don't have any experience with that. Sorry.
Okay, so this question will be spared. But RP, I agree with you. For the cost of 1,000 rupees, which you said 21835 and 20833, that's it. So in any case, then the trust will be on originator. Primarily because of the last slide, that the number of years of trust is there built up. You see, innovative biosimilars came with a bang, primarily to reduce the cost.
Yes.
But they haven't lived up to that expectation. The reason being, you see, if the biosimilar, the difference of cost was say 10,000 rupees or 15,000 rupees, I may still use biosimilars for a huge segment because they have potential to replace Avastin.
True.
That is the main indication, because Avastin is not an approved molecule, whereas biosimilars are approved by DCGI. They are approved molecules by DCGI, and they can be used. There is no doubt. But the cost difference of only say 800 or 1,000 rupees, and the number of patients, number of studies, number of RCTs, and the years of experience, then I think the originator still remains the king.
I think you're absolutely right, sir. And like there was a phase, we evolved our practice and with our experience, we were using the bevacizumab earlier because the other were too high cost. Then we shifted slightly when the cost came down. When the biosimilars came, the main thing was that they are going to reduce the cost of the treatment.
That hasn't happened. You see, but remember, biosimilars are similar, they're not same.
Patent was over, and they also reduced the cost of the innovator molecule. So practically the cost difference is not much there. And second thing is that now the second generation anti-VEGFs are available, the indications to move towards that is there. So the focus has been shifting now. So now in our practice also I moved to the more towards the original molecule rather than going to the biosimilar, because the cost effectiveness is almost the same.
Anirudh, your take on last comment about?
Sir, I think the only reason why one would go to biosimilar is cost. Yeah. And if really that is not a benefit, then there is no point in going to the biosimilar.
That's what I said. For a difference of 1,000 rupees, I will not. Yeah. So, last comment by Professor.
So, I'm just extrapolating it to glaucoma. That's not a very right thing, but that's what I'm going to do. In 1996, prostaglandins were launched. I remember sitting on one of the big halls in TOS, and they said, why don't we shift to PG for all patients? It's been 25 years down the line. Timolol is still in, and all the studies, new studies of the Rho kinase have come with non-inferiority to timolol and not to prostaglandin. That's one thing. That some drugs are here to stay. Second, biosimilars, no financial interest, of course, but we are a billion plus, 1.4 billion plus country. We've just heard that AMD is increasing, DR is increasing. Can we really afford it? If there is a wide need and everybody of you sits down, then the cost comes down, then it becomes affordable. I'm sure Ayushman also will take it up. But till then, you'll have to balance it out. And last, cost of the drug. In Indian mindset, what I'm saying is actually holds true. Cost of the drug and cost of a person accompanying and staying, that's intangible cost. They don't count that. They just cost the drug is counted. Thank you.
I agree with these comments. I think we will wind up the session with the few takeaways which I noted down from Anirudh's talk and others also. So, one is that any anti-VEGF agent can cause inflammation, whether it is ranibizumab, aflibercept. And I also believe Anirudh just said in that stronger the agent, more the potential for inflammation also. And second is, any fluid is bad. Any fluid is bad. Brolucimab has the potential to dry up all the compartments. You see, right from IRF to SRF to sub-RP also. And Anirudh, the one thing is, are we treating vision or are we treating OCT?
I think both, sir, because we do treat patients with 20/20 vision and some changes. You showed some patients who are 20/20.
So our aim should be to have an anatomical response, then only you can expect visual response. You see, drying is a very big challenge because there was one fluid theory which was propagated where they said some degree of fluid is tolerable. So my comment was some degree of fluid means this is a defeat of the molecule rather than the disease. And rest everything is good. I think protocol all of us discussed. Then patient satisfaction. Patient satisfaction is like RP also hinted, the more the duration, more the compliance, and better the patient acceptance. So with these, I think we will thank Dr. Namrata Sharma, the honorary chairperson of AIOSSC Scientific Committee, as well as all the sponsors, and very important, the entire R&R team for hosting this very useful symposium. Thanks, Anirudh, for joining, and hope to see you physically very soon. Thank you so much.
Thank you, sir.
See you.
I would request Professor Lalit Verma to present a memento to Professor Kirti and Dr. R.P. Singh. As we come to end of today's proceedings, on behalf of Army Hospital R&R and our head of the department, I would like to extend my sincere gratitude to each of you. With this note, I would like to request all of you to join us for dinner night at Officers' Mess. Thank you.